You're live.
Good morning, everyone. My name is Ali Munir, and I will be serving as a designated federal official for the U.S. Science Advisory Committee on Chemicals, which we refer to as the SAC. As a designated federal official, I'm responsible for opening this public meeting. I would like to thank Dr. George Cobb for agreeing to serve as chair of the committee and for this meeting. I would like to thank the members of the committee, ad hoc reviewers, and the public for attending this important meeting. We appreciate the time and effort that the committee members spent for preparing for this meeting while taking into account their busy schedules. Finally, I would like to thank my EPA colleagues for their hard work in preparing for this important review of EPA's 2024 draft risk evaluation for 1,3-butadiene. By way of background, the SAC is a federal advisory committee that provides independent scientific peer review and advice to the EPA on chemical-related issues regarding the impact of proposed regulatory actions on human health and the environment. The SAC provides advice and recommendations to EPA. Decision-making and implementation authority remains within the agency. The SAC is comprised of experts in toxicology, environmental risk assessment, exposure assessment, and related scientists. When needed, the expertise of these members is augmented by ad hoc peer reviewers who are temporary participants in the SAC activities, providing additional scientific expertise. In order to assist in reviews conducted by the SAC committee, as the DFO for this meeting, I serve as a liaison between the SAC and the agency. I am also responsible for ensuring provisions of the Federal Advisory Committee Act, or FACA, are met. SAC meetings are subject to all FACA requirements. These include open meetings, timely public notice of meetings, and document availability to the public. Copies of all EPA presentation materials, written public comments, and other documents related to this meeting are available in the public docket at regulations.gov. The docket number and the website are noted in this meeting agenda. As the designated federal official for this meeting, a critical responsibility is to work with appropriate agency officials to ensure that all appropriate ethics regulations are satisfied. In that capacity, the committee members receive training on provisions of the federal conflict of interest laws and scientific integrity trainings. In addition, each participant has filed a standard government confidential financial disclosure report. Our Deputy Ethics Officer for the Office of Program Support and their team, in consultation with the Office of General Counsel, have reviewed these reports to ensure that all ethics requirements are met. The SAC will review challenging scientific issues over the next 4 days. We have a very full agenda, and meeting times are approximate. Thus, we may not keep to exact times as noted due to discussions, deliberations, and public comments. As we move through the proceedings, we will move to the next agenda item if an agenda item takes less than the anticipated time. We strive to ensure adequate time for agency presentations, public comments, and committee deliberations. For presenters, SAC members, and public commenters, please identify yourselves as you speak into your microphones, since meeting is being webcasted, transcribed, and recorded. Members of the committee and ad hoc reviewers are encouraged to fully consider all written and oral public comments submitted for this meeting. I would like to note that we have a live video webcast of this meeting through YouTube. To access it, please go to the link in the meeting website listed in the agenda. Please note that the registration to attend this meeting is still open until the last day of the meeting. For members of the press, EPA Media Relations staff are available to answer your questions about this meeting. Please address all questions to press@epa.gov. At the conclusion of the meeting, the SAC will prepare a report as a response to the questions posed by the agency, the background materials, presentations, and public comments. This final report also serves as the meeting minutes. We anticipate the final report and meeting minutes will be completed approximately 60 days after the meeting is concluded. Again, I wish to thank the committee, ad hoc peer reviewers, and the public for your participation. I'm looking forward to both a challenging and interesting discussion today and over the next 3 days. I now turn the meeting over to our esteemed chair, Dr. George Cobb. Thank you, everyone. Dr. George Cobb.
Thank you. Welcome, everyone, and thank you to the EPA and all of the contractors for getting this meeting set up and for the work that went into preparing this draft risk evaluation along with all of the supporting documents. This time, I take a roll call really quickly so that we can make sure we know who on the committee is here. And I'd like to welcome all the committee members, both full members and ad hoc, for this review. Dr. Apte.
Here.
And would you tell us a bit about each one, just very quickly introduce yourself?
Yeah, hi, my name is Udayan Apte. I'm a professor at pharmacology, toxicology, and therapeutics at University of Kansas Medical Center, and my expertise is in liver disease and human health effects.
Thank you. Dr. Baker. Dr. Baker? Okay. Dr. Chasen.
Good morning. My name is Chris Chasen, and I'm recently retired from the Lifeline Group. My expertise is toxicology, risk assessment, particularly exposure assessment. Thank you.
Thank you. Dr. Ike.
Good morning. My name is Stephanie Ike. I'm an assistant professor at Emory University. I'm an environmental epidemiologist, and most of my work looks at how chemical mixtures impact health.
Dr. Fox.
Good morning. My name is Mary Fox. I'm an associate practice professor at the Johns Hopkins Bloomberg School of Public Health. I was trained in environmental and occupational health policy, and I do work in chemical mixtures and cumulative risk assessment.
Dr. Gentry.
Good morning, everyone. I'm Robin Ann Gentry. I'm a senior toxicologist and principal with Ramble in the Health Sciences Division, and I have over 35 years of experience in human health risk assessment.
Thank you. Dr. Graham. Dr. Heiger Bernays.
Good morning. My name is Wendy Heiger Bernays. My expertise is in toxicology and risk assessment. I am currently Chief of Research at the Mass Department of Environmental Protection and Clinical Professor Emerita at the Boston University School of Public Health.
Great, thank you. Ms. Jenkins.
Good morning, everyone. I'm a senior toxicologist at the Texas Commission on Environmental Quality, and my specialty is regulatory toxicology and risk assessment.
And you have a nice background on your slides or on your
Thank you.
Zoom. Dr. Merced Nieves.
Good morning. My name is Francesca Merced Nieves. I'm an assistant professor at Icahn School of Medicine at Mount Sinai in the departments of public health and environmental medicine. My expertise and research focuses on chemical mixtures and its effects on brain development and child development.
Thank you. Dr. Rubin.
Good morning. My name is Rainbow Rubin. I'm Science Director at Breast Cancer Prevention Partners and affiliated with UC Berkeley Environmental Health Sciences Division. I'm an environmental health scientist with expertise in environmental epidemiology and exposure assessment. Thank you.
Thank you. Dr. Samuel. Dr. Samuel?
Yes,
Mr.
good
Oh,
morning.
there you are.
My apologies, my video is slow. Good morning, everybody. My name is Jennifer Samuel, Dr. Jennifer Samuel. I am, and can you hear me?
We can now.
Okay, my apologies about that. Something is going on. My name is Dr. Jennifer Samuel, and I am
I'm sorry, you cut out
I'm
again.
an exposure and risk assessment scientist, as well as a certified industrial hygienist. Can you hear me right now?
You're
I
cutting
will try
out.
to get
You're cutting out. Can we
my
maybe
apologies.
come back? Is that okay? Mr. Wright.
Yes, I will. I'll see what I can do. Sorry about that.
Go ahead, Mr. Wright.
My name is Mike Wright. I'm the retired director of health, safety, and environment for the Steelworkers Union, which, despite its name, represents the majority of organized chemical workers and workers in the energy industry, among many others. My expertise is industrial hygiene.
Thank you. And now for our ad hoc members, Dr. Santos Bourgois.
Yes, good morning. I am Carlos Santos Burgoa. I am professor of global health and environmental and occupational health at the George Washington University, and I am a medical doctor with training and expertise on environmental and occupational epidemiology. Worked on One Review Today for many years.
Thank you. Dr. Roby.
Good morning. Well, we'll try that again. Good morning. I'm Catherine Roby. I'm at the University of Kansas Medical Center, a professor in cell biology and physiology and obstetrics and gynecology. My focus is reproductive endocrinology with an emphasis on the ovary.
Thank you. Dr. Johnson.
Hello, I'm Mark Johnson, former director of toxicology for Defense Centers for Public Health in Aberdeen, our Defense Health Agency. I'm also the current president of the Society of Environmental Toxicology and Chemistry North America. And my background's in environmental toxicology, occupational toxicology, and risk assessment.
Thank you, Mark, and welcome back for a short stint. Dr. McKenzie.
Good morning, I'm Lisa McKenzie. I'm an associate professor at the Colorado School of Public Health, University of Colorado. My expertise is in exposure and risk assessment, as well as environmental epidemiology.
Thank you. Dr. Fairbrother.
Yeah, good morning. I'm Ann Fairbrother, retired as a principal from the Environmental Sciences Division of Exponent. And my expertise is in ecotoxicology and ecological risk assessment.
Thank you. Dr. Eastman.
Good morning. My name is Dave Eastman. I'm a emeritus professor at the University of California, Riverside. My expertise is really in genetic toxicology and chemical carcinogenesis.
Thank you. Dr. Hopkins. Dr. Hopkins?
Yes. Can you hear me?
Yes.
Lauren Hopkins. I'm a professor in the practice of statistics at Rice University and Chief Environmental Science Officer for the City of Houston. And my expertise is in environmental statistics and risk assessment.
Thank you. Dr. Bean Friedman.
Good morning. I'm Laura Bean Freeman. I'm a senior investigator in the Occupational and Environmental Epidemiology branch at the National Cancer Institute. As the name implies, I am an occupational and environmental epidemiologist conducting work in studies of industrial and agricultural workers.
Dr. Finner Crisp.
Good morning. I'm Penny Finner Crisp. I've been an independent consultant for a little over 20 years after having had a 22-year career at EPA and 4 years at the International Life Sciences Institute. My areas of expertise are toxicology, risk assessment, and science and regulatory policy.
Thank you. Dr. Mayer.
Hello, everybody. I'm Andy Mayer. I'm with Integral Consulting and formerly associate professor of industrial hygiene for the University of Cincinnati. And my background is in industrial hygiene and occupational toxicology.
Great. let's go back and see if some of the other folks have joined that we missed. Is Dr. Graham there?
Dr. Graham will not be able to participate this week.
Who else did we miss? I think that's it. So thank you, everyone, for.
Do we need to go back to Dr. Samuel?
We can try that. Sure.
Okay.
Are
If
you
she hasn't fully
there?
introduced herself.
Yep. Dr. Samuel, are you there?
Okay.
Seems like that audio may not be working still. So
We do have a phone option. So and anyone who's having some technical difficulties via Zoom, they do have the option of calling in.
right. Yes. Okay. So thanks everyone. And I can turn it back over. Allie, do you need more time, or do we just move right into the meeting with the?
Let's just go ahead and move right into the meeting. So next on the agenda is our next speaker to provide opening and welcome remarks, Dr. Nancy Beck. She is with the Office of Chemical Safety and Pollution Prevention, and she is our Principal Deputy Assistant Administrator, and I will now turn it over to Dr. Beck for opening and welcome remarks. Dr. Beck?
Thank you, Allie. I appreciate it. Good morning, everyone. It's great to be with you all virtually today. I am super excited to be back at EPA as the Principal Deputy Assistant Administrator in the Office of Chemical Safety and Pollution Prevention. While this is my second time in this position, it's actually my third stint at EPA. But more importantly, this is exciting because this is the first SAC meeting of 2025 and of this new administration. I want you to know that OCSPP is committed to ensuring that we're relying on the best available science throughout all our decisions. And we're going to work to ensure that all our scientific evaluations are designed to inform the decisions that TSCA requires us to make. Our team in the TSCA program has been working really hard on the 1,3-butadiene assessment, and in my opinion, we should be grateful for all the good work and the thoughtfulness that they put into this complex assessment. I know I am very grateful. I also want to thank the team that is going to work hard over the next 4 days to ensure that this peer review runs as smoothly as possible. I recognize that in a virtual universe, there will likely be some kinks, but they've worked hard to develop processes and procedures to help prevent them and to fix them quickly. So fingers crossed that will go smoothly. Peer review and public comment are integral steps in ensuring the quality of our documents. I want to thank our peer reviewers for giving us their time and their scientific expertise this week. You're not only necessary, but I expect that your final report will have tremendous value in helping to improve our risk evaluation. And I want to thank our stakeholders for being here and for providing your important perspectives today and throughout the week. Your comments will be considered by the EPA team and also by the peer reviewers as well. In fact, I hope the peer reviewers will engage with you and use the comment periods to ask you any questions they may have on your remarks or on the materials that you provided in advance. Those were all provided to the peer reviewers so they can engage you. This dialogue is a very important part of our process. Peer review gives us confidence in the data and the methods that we're using to evaluate the risks from the chemicals and to ensure we're using the best available science. It also helps us to identify inaccuracies, data gaps, and other issues. The risk evaluation you're discussing today will ultimately be the basis for any needed protections or restrictions for 1,3-butadiene. And that has real consequences for real people, for real government agencies that need butadiene as a mission-critical chemistry, and for real companies that provide jobs to thousands of citizens. So we must ensure that we're protecting human health and the environment, and if something is missed or if we got something wrong, we need to know. We also need to know if we're being overly conservative, so we're not led down a path of unnecessarily restricting a chemical. We certainly don't want to stifle innovation, nor our country's economy. So this is especially important as we work to further refine the risk evaluations to use data that better reflects real-world exposures. And the 1,3-butadiene assessment is a great example of how we're moving towards a tiered approach in our assessments. Using this kind of approach will make our work more streamlined and hopefully more efficient. Specifically, for the risks to the general population from 1,3-butadiene exposure in ambient air, we're asking for your feedback on our inputs and our model refinements. We started with a very high-level screening level assessment. And the screening assessment supported the need for more refined modeling of ambient air concentrations to ensure that we had a more comprehensive understanding of the potential for risk. We then issued a supplemental evaluation where we used facility-specific data to refine the risk estimates to provide important updated information for our risk evaluation. And we want to know what you think about this. We want to know what you think about the strengths and the limitations of the modeling approaches that we used. Our goal is for our risk evaluations to be a true representation of potential risks for both the general public and workers, thus ensuring that our risk management approach will be practical and workable for those that we're trying to protect. That's why we're having a robust dialogue over the next 4 days, and that's why this is so important. It is not about politics or personal opinions. This is about the science. We don't want a superficial review. That's not why we're here. We need a fulsome discussion that ideally results in consensus, and that's why we did a full peer review, not a letter review. So to the peer reviewers, if one of the other peer reviewers says something you don't agree with, please speak up. Similarly, if one of the stakeholders makes a comment you don't understand or you need more information on, please ask the stakeholder to answer the question and clarify their position. Delivering a high-quality scientific review of this chemical means that consumers can be confident in its safety. It gives industry certainty that we're following the law, that we're using the best available scientific information to conduct our reviews, and that any restrictions we need to put in place will be protective and necessary. Ultimately, the discussion that happens here and the resulting peer review report will build trust and credibility in the risk evaluation and in our TSCA program. Peer review also helps us to maintain an honest and collaborative relationship with all our stakeholders, whether it's for this chemical or for any other one that we may review in the future. So thank you again to the Super EPA team for all the work leading up to today's meeting. Thank you again to our peer reviewers and our stakeholders for sharing your thoughts and helping us to improve this risk evaluation. I hope you will have a great discussion over the next few days, and I look forward to seeing your report. Allie, I'll turn it back to you now.
Thank you, Dr. Beck. I will now go ahead and turn it over to Dr. Cobb to kick off a series of the OPPT technical presentations. Dr. Cobb?
Thank you. So now we'll turn over to some summaries of the really hard work that EPA has done in this assessment. And the first presenter is Dr. Sheila Healy, who's going to talk to us about the overview of this draft risk evaluation.
Good morning, and thank you, Dr. Cobb. My name is Sheila Healy. I'm the supervisor of Risk Assessment Branch 5 in EPA's Office of Chemical Safety and Pollution Prevention, Office of Pollution Prevention and Toxics. Thank you to the members of the SAC for their participation and the feedback that we'll receive throughout our meeting. I also want to thank the public commenters that we will be hearing from as well. So today, our focused discussion will be on the draft risk evaluation for 1,3-butadiene. Next slide, please. So I'd like to begin by acknowledging, can we go back to slide 2, please? Okay, I apologize. I think we skipped a slide in the deck about acknowledging, but I hope that I can make it public later. So, but here I jump to the background. This slide presents a brief review of 1,3-butadiene and its sources. Butadiene is produced in petrochemical processing, namely as a co-product in ethylene manufacture. 1,3-butadiene is used as a building block in the manufacture of synthetic rubber, resins, and plastics. Butadiene most commonly joins with itself, styrene or acrylamide, to form a stable and durable polymer. Styrene butadiene rubber, for instance, is used to make tires. As much as 5 billion pounds of 1,3-butadiene is produced annually in the United States. We note here that 1,3-butadiene is also generated from the burning of fuel, wood, and tobacco. However, combustion sources of 1,3-butadiene exposure will not be quantitatively assessed in our risk evaluation. Next slide, please. So here I want to give a brief review of our draft risk evaluation and supporting documents as submitted to the docket and depicted in this map. This document map will also guide our presentations today. As we progress, you will hear our team describe a fit-for-purpose risk evaluation, which focuses on the air pathway. We determined that there is no appreciable exposure to 1,3-butadiene monomer from plastic or rubber consumer products. And because 1,3-butadiene is neither appreciably detected nor expected in water or on land, our risk evaluation includes a qualitative environmental exposure assessment. Next slide, please. Can I just take a break to sort out?
Yeah, guys, I think there's a different deck to load up. Give me just a moment.
Okay.
Thanks.
So while we're waiting on the slide deck to get ready, Dr. Samuel, maybe you can give us a brief mic check to see if your audio is working now.
Yes, how is that? Is that better now?
Very nice.
Okay,
Perfect.
great. I'm sorry for the problems earlier. I don't know why it went unstable, but I'm in the office, so it should be good. So I
All right.
apologize for that.
Thank you.
Thank you very much.
Can the slides please be projected on screen? I'd like to see the slides. One moment as we are projecting the slides.
One second. This is Charlene Matten, and we are looking because the April 1 through 4 slide deck is
That's in case you want
going
to
to
go
be
back to the
shown in a
acknowledgement.
minute. If you can just take 1 minute, because we have to get that back up. Thanks.
Sheila, did you want to review the acknowledgements or you want me to go ahead? Forward.
I'd like to acknowledge this is a really great team.
Okay, so we could go ahead and continue with the presentation. Dr. Healy, please continue. Thank you.
Okay, thank you. This is my favorite slide, and I did want to begin by acknowledging our primary authors in Risk Assessment Branch 5. It took a mighty group of talented scientists and experts to get us to this point. This slide lists all the esteemed authors and contributors that we would like to publicly acknowledge. I also want to thank our technical support staff and contractors who make much of this work possible, as well as technical experts from within other offices at EPA. Next slide, please. I think I did, this is basically the same slide, but I did want to highlight again, if it was not on the first slide, that we are not including combustion as sources of 1,3-butadiene exposure, even though we acknowledge that it is generated from burning of organic material. All right. Okay, so this is the document map that we went over. So I think I can go on to the next slide, please. Right. Okay, so as an overview, the outline for our presentations during the meetings are shown in these next two slides. The technical presentations are aligned with the charge questions posed by EPA, as shown as in this figure and in the next slide on the right-hand column. Yeah. So I will continue with a brief introduction to TSCA. Next, Adi Adegbule, EPA's 1,3-butadiene assessment co-lead, will address environmental fate. Our human health hazard team of Keith Jacobs, Apisasi Haran, and Ann Wong will then walk us through the hazard characterization for both non-cancer and cancer. Next, Kit Lee, our other EPA assessment co-lead, will describe our assessment of general population exposure from facility releases to air. He will also briefly summarize our qualitative assessment of consumer exposure. Katie Taylor will then present our occupational exposure assessment. And finally, Mr. Lee will go over our document organization to set up our final charge question. Next slide, please. So the TSCA statute, as amended by the 2016 Lautenberg Act, provides the regulatory context in which we perform our existing chemical risk evaluations. Next slide, please. TSCA Section 6B requires EPA to conduct risk evaluations to determine whether a chemical substance presents an unreasonable risk of injury to human health or the environment. In order to do that, we are asked not to consider the cost or other non-risk factors. TSCA requires that we include potentially exposed or susceptible subpopulations identified by the EPA as relevant to the risk evaluation under the conditions of use. We are asked to evaluate existing chemicals with a clear and enforceable deadline. EPA has approximately next slide. EPA has approximately 3.5 years to complete risk evaluations after the final designation documents are published. TSCA requires EPA to use the best available science, using reasonably available information, and make decisions based on the weight of scientific evidence. The risk-based chemical assessment is then developed without consideration of cost or other non-risk factors and with consideration of risks to potentially exposed and susceptible subpopulations determined to be relevant to the risk evaluation. Next slide, please. So the risk evaluation considers exposure and hazards to determine whether a chemical substance presents an unreasonable risk to human health or the environment under the conditions of use. The risk evaluation is the primary science support document that the agency uses if it is necessary to issue regulations to address unreasonable risk. Finally, to the extent that the administrator makes a decision based on science, the administrator shall use scientific information, technical procedures, measures, methods, protocols, methodologies, or models employed in a manner consistent with the best available science as addressed in Section 26H of TSCA. Next slide, please. So here I'm going to describe some key scientific terms critical to our work. Specifically, TSCA requires EPA to use the best available science and the weight of scientific evidence. In determining best available science, EPA needs to consider the extent to which scientific information, technical procedures, measures, methods, protocols, methodologies, or models employed to generate our information are reasonable and consistent with the intended use of the information. We also need to consider the degree of clarity and completeness with which data assumptions, methods, quality assurance, and analyses employed to generate the information are documented. The extent to which the variability and uncertainty of the information in the procedures, measures, methods, protocols, methodologies, or models is also evaluated and characterized. That's why we're so focused on methodologies in our charge questions. Finally, the agency must consider the extent of independent verification or peer review of the information of these procedures, measures, methods, protocols, methodologies, and models, hence the reason why we are asking for your input this week. Next slide, please. So in order to meet the requirements under the law, TSCA risk evaluations must be made on the weight, based on the weight of scientific evidence. EPA relies on established agency guidance documents, which provide consistency and formality to the process. The guidance documents help us integrate multiple lines of evidence. The weight of scientific evidence assessment is based on the strengths, limitations, and interpretation of the data available across multiple lines of evidence, and how these different lines of evidence may or may not fit together when drawing conclusions. The weight of scientific evidence assessment also examines multiple lines of evidence from scientifically relevant published or publicly available studies in peer-reviewed scientific journals, studies conducted in accordance with OECD or EPA guidelines, and any other studies, scientific information, or lines of evidence that are of sufficient quality, relevance, and reliability. These are evaluated across studies and endpoints into an overall assessment. EPA has provided a summary of the weight of scientific evidence narrative to accompany a detailed analysis, which transparently describes the conclusions as well as explains the selections of studies or effects used in main lines of evidence, which then serve as a relevant basis for our conclusions. Next slide, please. So when we begin our analysis, there are a number of considerations. We look at sources of potential exposure, the pathways by which those exposures may occur, the media in which those exposures could take place, the people and organisms that may be exposed, and then the routes by which people and organisms may be exposed. Next slide, please. So in order to ensure the highest quality science and transparency, risk evaluations go through several rounds of various internal and external reviews. Some of our internal review processes include peer review with technical teams within the existing chemicals risk assessment program, review by our science advisors, and management reviews. We also work collaboratively with other offices within EPA and sometimes those external to the EPA. With this evaluation for 1,3-butadiene, we've collaborated specifically with the Office of Research and Development and the Office of Air and Radiation, seeking early guidance on methodologies and feedback. Our external review process includes a public comment period and review by the SAC. Stakeholder engagement from various entities is also considered, whether it be the manufacturers of existing chemicals or other stakeholders, as well as from our NGOs. Next slide, please. So with that, I'd like to thank you for your attention, and I am happy to take any clarifying questions. Thank you.
Thank you. Are there any questions from the committee? Okay. Well, seeing that I don't have a question, I do have a comment. I really appreciate that presentation. It was very good and very thorough. And it does point to the charge that we have on this committee and that you have in your office to do these risk assessments without consideration of cost or other things that do not necessarily influence the risk. And I'd like to point out that even though Deputy Administrator Beck mentioned several things that would be considered in policy, that does not factor into what we are doing today. We're simply considering the scientific evidence related to risk, and I appreciate your presentation pointing that out to us today. So thank you very much for that nice presentation. Okay. Next, we have Dr. Adebuli and talking about environmental exposures.
Thank you very much, Dr. Cobb. Hi, everyone. I'm Adi Adebuli, one of two lead assessors for the 1,3-butadiene risk evaluation, and I'll be presenting the environmental exposure.
I can't hear Dr. Adebuli.
I'm sorry, this is George Kopp. I inadvertently muted that's my mistake.
Thank you.
So it says Kathy, Dr. Denisiu's mic is muted, and that is my fault.
Yep, I think you should be set now.
Can you hear me now?
Yes, and again,
Yes.
this is George Cobb. My apologies, I did that.
All right, thank you. So thanks again. I'm Adi Adibule, one of two lead assessors for the 1,3-butadiene risk evaluation, and I'll be presenting the environmental exposure assessment and analysis. Next slide, please. Okay. This presentation provides background for charge question 1. The charge question is supported by materials in sections 3, 4, and 5 of the draft 1,3-butadiene risk assessment, as well as the draft chemistry, fate, and transport assessment, EPI-suite modeling results, environmental media concentrations, water quality portal data, and draft environmental release and occupational exposure assessment. Next slide, please. The document map highlights that charge question 1 is primarily supported by the material presented in the physical chemistry and fate assessment, the environmental media assessment, the environmental releases and occupational assessment, along with other technical support documents. The information is summarized in the environmental exposure section of the 1,3-butadiene risk evaluation and informs the environmental risk characterization section. Next slide, please. We will go over the chemistry, fate, and transport properties of 1,3-butadiene, environmental releases, monitoring data, and key conclusions which support a qualitative assessment for the land and water pathways. Next slide, please. This figure demonstrates the fate and transport processes that 1,3-butadiene will undergo in the environment. As indicated by the broken arrows, many of these processes are not going to be significant. In this assessment, we have used chemistry and fate properties, release information, and available monitoring data to focus our assessment on the most relevant exposure pathways. We will discuss the fate processes and our logic behind conducting a qualitative assessment for specific pathways in more detail in the following slides. Next slide, please. So 1,3-butadiene is a highly volatile gas at ambient temperature, and it is not very soluble in water. Thus, it will not persist in land or water due to rapid volatilization from land and water surfaces. It is highly reactive in the atmosphere and photodegrades with a half-life of between 1.6 to 9 hours to yield formaldehyde and acrolein. This means that 1,3-butadiene will not persist or undergo long-range transport in air. 1,3-butadiene has a low sorption potential to organic matter. It will therefore not persist in sediments or soils and will remain in the vapor phase in the atmosphere. As a result, it has a low tendency to undergo dry deposition from air. Finally, its bioconcentration factor suggests low bioaccumulation potential in terrestrial or aquatic organisms. Overall, the chemistry and fate properties of 1,3-butadiene suggest that it will not persist in water or land. Next slide, please. In 2021, the Toxics Release Inventory reported that over 99% of environmental releases of 1,3-butadiene were made to air. About 0.1% went to water and another 0.1% to soil. Fugacity modeling based on these releases indicate that once released to air, 1,3-butadiene will primarily remain in air. As a result, air is expected to be a pathway of exposure to 1,3-butadiene. Next slide, please. Data from the water quality portal indicates that 1,3-butadiene was not detected in over 200 surface water samples collected between 2012 and 2020, and over 7,000 groundwater samples collected between 2016 and 2023. There was one sample reported in error by the National Water Information System, and a few samples in Arizona ranging from 2 to 40 microgram per liter collected between 2013 and 2014, none after that. The samples were reported by the storage warehouse, and a method detection limit was not reported for those samples. Data from the third unregulated contaminant monitoring rule showed 2 detects out of over 36,000 drinking water samples collected between 2013 and 2015. In conclusion, majority of the monitoring data confirms that 1,3-butadiene is not detected in surface water, groundwater, or drinking water. Next slide, please. So in summary, 1,3-butadiene will not persist on land due to high volatility driven by a high vapor pressure, low sorption potential to organic matter, and limited releases to land. Majority of monitoring data confirm that 1,3-butadiene is not detected in groundwater, and a low bioconcentration factor indicates that 1,3-butadiene has low bioaccumulation potential in terrestrial organisms. These conclusions support EPA's decision to develop a qualitative assessment of 1,3-butadiene contributions to land exposure for both human and environmental risk. Next slide, please. Similarly, 1,3-butadiene will not persist in water due to high volatility driven by high Henry's law coefficient, low sorption potential to organic matter, and limited releases to water. Monitoring data indicates that 1,3-butadiene is not detected in surface water and the majority of drinking water samples. A low bioaccumulation factor indicates that 1,3-butadiene has low bioaccumulation potential in aquatic organisms. These conclusions support EPA's decision to develop a qualitative assessment of 1,3-butadiene contributions to water exposure for both human and environmental risk. And thank you for your attention. I'll take any clarifying questions.
Excellent. Thank you. Now to the committee and ad hoc members. And when I say committee, I mean committee and ad hoc members for the duration of this for this week. Any questions or clarifying comments? Dr. Johnson.
Yeah, thank you so much for your presentation. I did thoroughly read the documents, at least I hope I did. And you mentioned that the breakdown products were acrolein and formaldehyde. Did you look at the quantities of acrolein and formaldehyde that may be created from photolysis of released 1,3-butadiene?
Yes, we did look at that. We're not able to get exact amounts, but we know it's about a 50-50 breakdown product of formaldehyde. And then I think acrolein too is about 50%. So like 1-to-1 breakdown of both acrolein. I think acrolein is slightly higher than formaldehyde, but they're about 1-to-1.
Okay, thank you.
What we found, yeah.
Dr. Santos-Bourgois.
Yes, thank you very much for the explanation. I don't know when to address questions or comments until we go into the charge questions or not. But I just have a concern in the freight and transportation scheme that you show. Nothing is identified in relation to injection wells or sites, heavily polluted sites like national priority, these sites that could eventually be point sources for potential exposure. I wonder if that was ever considered.
If I understand your question, you're asking if 1,3-butadiene is being released to underground wells? Did I understand your question?
Yeah, if it was considered that pathway.
Okay, yeah, thank you for your question. So from the TRI information that we got, most of the releases went to air and just a very small percentage went to water and land. So I would assume that if there was any special releases like you're talking about, maybe it might be covered in that percentage, but that's the information that we had to work with, is that most of it, over 90%, is going to air, and a very small percentage going to underground injection wells or water. Yeah.
Thank you for that question and answer, Dr. Chase.
Hello. My name is Dr. Chasen, and I have two questions, but Dr. Cobb, I'm not sure if this is the right place. One has to deal with the industrial, air residues, and one has to do with off-gassing from plastics and other end products. Would EPA prefer I wait till some other place, or is this the appropriate place to ask those questions?
So here's my thought on that is, let's get it asked, and if it is best answered at a different place, we can the EPA can tell us that.
Okay. All right. Thank you. The first one has to do with the issue of both worker exposure, but the air concentrations around industrial facilities or work facilities, however you want to define that. How do we know how well the data from the industries, as reported in like the CSB worker incident reports, actually represents the potential exposures or air concentrations that are experienced by the workers? For example, and I ask these questions because I personally truly don't know what the, if you will, industry practice is, and I'm hoping that EPA does. Who decides what gets reported? And for example, are minor, quote, accidents or process deviations, are those reported? Are repetitions of minor deviations reported? Are there parts of the data that are ground truth then with monitoring data? From the EPA scientist's point of view, what are the most valuable parameters and factors found in those kinds of databases? And what desirable factors and parameters are not covered or just missing in terms of overall information about atmospheric residues, both in industry, around industry, and in other places where they would expect it to be? So that's my first question, Dr. Cobb. The second one is related in theme to that question, but it's the same kind of thing vis-a-vis end products. EPA's my question interest was piqued because the very first slide said there is no 1,3-butadiene in plastics or rubber, end sentence. Well, EPA notes convincingly that the physical characteristics such as volatility and reactivity make it likely that unreacted residues of the chemical would be small in any end product as it enters commerce, coming right out of manufacturing, or it's used in another industrial facility. Are there indeed studies which test over time and under different physical conditions for concentrations in the air consequential to the off-gassing of any residue of the chemical in those kinds of products? Thank you. Thanks for the opportunity for the question.
Okay. Thank you. And Dr. Adebuli, do you have a response? And I think maybe the occupational exposure is not part of this, but maybe for later. But either one of those questions, if you care to address.
Yeah. Thank you, Dr. Cobb. Yes, I was going to, and thank you for your comment, Dr. Case. And I was going to ask for you to wait for later presentations on occupational and consumer, and hopefully your questions will be answered during those sections.
So are you saying both questions?
Correct.
Okay, that's good. And Dr. Chason, if you'll just remember that, and we'll circle back. Maybe we won't have to ask the questions in as much detail, but just to circle back to them.
Right, I will, Dr. Cobb, and thanks for the opportunity. Maybe that at least gives some fair warning that that's one of my concerns. So
Yeah, I think that's
Thank
good.
you.
Thank you
Good,
very much. Dr. Fairbrother.
Thank you. When you're talking about different potential environmental exposures, I'm wondering if you considered spills, particularly during transportation, which could then spill large amounts of liquid 1,3-betadiene into water or soil.
So thank you very much for your questions. We did, based on the PCAM properties of 1,3-butadiene, we expect rapid volatilization from spills. We know that 1,3-butadiene is not a liquid at atmospheric pressure, so it will quickly evaporate if it is released as a liquid.
Okay, but is it going to be incorporated in the document as, that it was considered in that way?
We do discuss our expectations of 1,3-butadiene in the FAPE chemistry and FAPE TSD and how we expect it to behave.
Okay.
So Dr. Fairbrother, thank you for that question. And I think I am, the way that I read the document, it does not explicitly say that spills have been considered. And I think what Dr. Fairbrother is asking is that it be explicitly stated one way or the other. I think you're saying it should be, spills should be considered, and that should be stated in the document. Is that correct, Dr. Fairbrother?
Yeah, that's correct, because we do need to think about the possibility of acute exposures, particularly in water.
So that was a question, and now the dialogue you and I are having is bordering on the response to the charge. So let's save most of that conversation for later. And that's very good. And I did have, I wanted to kind of follow up on Dr. Well, first of all, let's go and see if there are any other questions. I kept talking because I didn't see any other hands raised. I did have a slight follow-up to Dr. Johnson's question is, there was a mention that formaldehyde and acrolein would be formed, but I think his question was, did you estimate the amounts or the concentrations of formaldehyde and acrolein would be present in the atmosphere based on that degradation? And if that wasn't his question, that's mine.
Okay.
Thank you, Dr. Cobb.
All right. Thank you for your question. We focused the risk evaluation on 1,3-butadiene, so we didn't go and look for information on formaldehyde and acrolein.
Okay. So Mark, maybe we can switch, Dr. Johnson, maybe we can come back to that during the response to the charge. Dr. Mayer.
Just a quick, I think, point of a reference. I think section 3.7 in the environmental and occupational exposure appendix does actually have a section on spills that's in the distribution of commerce, because I remember reviewing that. So there's a qualitative description of spills from the environmental and occupational exposure from distribution and commerce scenarios.
It's great information. Thank you for that. And that's why we have lots of people reviewing these documents. Seeing no additional questions, I'd like to thank Dr. Adebile for a really nice presentation and all the hard work that went into that the environmental assessment. And now we can move on to our next presentation by Dr. Jacobs. And this will be the human health hazard assessment.
One second. Thank you. We will now present the Human Health Hazard Assessment. The presenters for this work are Keith Jacobs, Abhilash Sasitharan, and An Huang. My name is Keith Jacobs, and I will begin with a short introduction and background on how the assessment was performed. Next slide. Here is the 1,3-butadiene risk evaluation document map. This presentation will cover the human health hazard assessment, shown in yellow within the context of the overall risk evaluation. Next slide. EPA used a refined systematic review approach for identification of relevant hazards across epidemiological, animal toxicological, and mechanistic evidence streams. Details of this approach will be covered on a later slide, but in short, EPA used study summaries from existing governmental assessments together with evaluation and extraction of individual studies identified by EPA to create the hazard database, which was then integrated across evidence streams to support conclusions on relevant adverse health effects. EPA then identified the most robust endpoints and derived hazard values from key studies representing these adverse health effects. These health effects were binned into one of 4 duration categories based on the length of exposure that may result in the adverse outcome. Acute effects can result from a single exposure within a 24-hour period. Intermediate effects require repeat doses, but over a short period of time, and apply to any repeat exposure covering less than 10% of lifetime. Chronic effects require repeated exposure for greater than 10% of lifetime. And based on our dose-response approach, cancer was considered applicable to exposures averaged over an entire lifetime. The weight of scientific evidence supporting conclusions from all steps of the process were then considered in characterizing EPA's confidence in these hazard values for risk characterization. Next slide, please. 1,3-butadiene has a robust assessment history within the US government and around the world. EPA last assessed the human health hazard of 1,3-butadiene in 2002 with an ORD IRIS assessment that provided acute and chronic non-cancer reference concentrations as well as a cancer inhalation unit risk, or IUR. ATSDR in 2012 reviewed the non-cancer information but did not derive a hazard value, while Texas and California did establish non-cancer hazard values in 2012 and 2013, respectively. Health Canada's assessment was used to support the 2002 EPA IRIS assessment, while many other countries have also assessed 1,3-butadiene since the year 2000. Next slide. As mentioned on a previous slide, EPA used a refined systematic review approach by using existing assessments as a starting point and filtering the pool of studies to focus efforts on the most important studies that might support dose response. EPA relied most heavily on the 2002 IRIS and 2012 ATSDR assessments. This slide illustrates the process we used to filter references and prioritize those most relevant for dose response assessment. A similar version of this flowchart was applied to both animal toxicology and epidemiology references. We began by including both peer-reviewed literature and data provided to the agency that met the screening criteria. References were first categorized into 2 groups: those considered for dose response analysis in the most recent IRIS or ATSDR assessment, and everything else. References included in the IRIS assessment or ATSDR that were considered for dose response analysis were directly advanced to data quality evaluation and extraction. For the other references, EPA prioritized data with sufficient quantitative exposure data, such as those with multiple exposure groups. References that provided only qualitative data or had limited quantitative exposure levels were not used in dose response analysis. However, these qualitative or limited data studies were still valuable and did contribute to hazard identification and evidence integration. Importantly, EPA did not exclude any studies from at least qualitative consideration unless there were severe data integrity concerns that made the results wholly unreliable. In addition to this filtering process for animal tox and epidemiological studies, EPA also performed a manual search and filtering of mechanistic and toxicokinetic references. As will be presented on the following slides, these data are important for determining the mode of action and human relevance for these observed adverse apical outcomes. EPA used the database of supplemental or otherwise PICO-excluded studies from the initial 2019 literature search, as well as any newer published studies that informed the significance of 1,3-butadiene metabolites. These studies greatly contributed to the overall weight of scientific evidence for each endpoint. Next slide. Thank you for your attention. I will now take any questions.
Thank you. Let's see, go to the committee for any possible questions. I see Dr. McKenzie.
Thank you for your presentation. This is Dr. McKenzie. How did EPA consider cell level and molecular level effects in the non-cancer hazard assessment?
So any specific questions about the non-cancer assessment, we'd prefer to take following our presentation on our non-cancer evaluation, which will follow me.
Okay.
But if you're just asking about systematic review, is that the question?
Yes.
So as I mentioned, our formal data evaluation process focused on animal and epidemiological references. However, we manually reviewed any relevant studies that supported mode of action, toxicokinetic, or human relevance. And those did focus on cellular as well as in vivo studies. And we discuss those and cite them throughout the human health assessment.
And Dr. McKenzie, if you have further detailed questions about that, you can ask that during the next couple of presentations.
Okay, thank you.
Thanks for that question. Dr. Fenner-Christ.
Yes, my question is, could you point out to me where in the IRIS document or the IRIS summary the agency has generated an acute reference concentration?
There is not, there is an acute reference concentration in the IRIS assessment. If you want specific reference for that, we can provide that at a later time. But the 2002 IRIS assessment does have an acute reference concentration.
Well, I would beg to differ from you, but I'd be interested in seeing what you find. They've never generated acute RFCs.
So, and yeah, and if so, we would need an answer to that question while we're having our meeting this week. So, and if the answer is there's not one, then that's a reasonable answer. But we will need an answer this week.
George, I believe it's in our background document. It's not in the formal IRIS report online, but the background document did generate one.
Okay, great.
Thank you.
Thank you, Dr. Eastman. Dr.
Yes, thank you. Thank you very much. I would like to better understand the process of selecting the data and your screening criteria for that. Because you mentioned only severe quality concerns in the review of the reference and all that. Can you be more explicit? What do you mean by severe quality concerns that make you exclude some references?
I can give a specific example. So there was one or two studies or subsets of studies done by IBT labs in the 1970s, which have been confirmed to have severe data integrity concerns with controls, animal husbandry, and many other statistical issues that make the data generally unreliable. That was pretty rare, but there were one or two subsets of studies. So that was an example where no part of the results would be considered reliable. But outside of something extreme like that, everything was considered, at least qualitatively. And details on how we did the filtering and how we made these decisions are described in the systematic review protocol, which is one of the supplemental documents that should be in the docket and as part of the overall risk evaluation package.
Yeah, that's precisely. I went through all of that, and I found some absences that I would like to consider for you to consider when we get into the charge questions.
That's exactly right. So thank you for that question. Dr. Fox.
Hi, yes, Mary Fox. So I'm trying to understand the stages or the phases of your literature search and the systematic review, because it sounds like you did multiple. There were multiple. There was a 2019 search, then there was also gathering from the previous documents, and then there was a supplemental to get newer research. Can you just review that for me again, please?
Yes. So we had a full literature search done in 2019 of all available information that could be found. The first consideration was a refinement approach of filtering to focus really on the studies that we most care about, those that might drive quantitative hazard values. So we did a filtering of the entirety of that database by looking at previous assessments, with the assumption that if something was already a key study for a previous assessment, it's still going to be a key study. And if it was not a key study for previous assessment, it was unlikely to suddenly become a key study. So it's essentially we focused on what was already determined to be a key study before and any other potentially key study not covered by those prior assessments. So a major example there might be data submitted to the agency, whether before or after the cutoff date. For example, ATSDR would not have data submitted to EPA from industry. So those would automatically be considered because ATSDR couldn't have looked at them. But if something was in the public literature prior to 2012 and there was no discussion, or it was considered only supplementary, we assumed that it was therefore likely to be supplementary and we could focus our efforts on the most important data. So beyond that, because our literature search is from 2019, there were both updated literature submitted to the agency that either wouldn't have been covered in 2019 or wouldn't have been even covered in our 2019 search. Additionally, there were mechanistic data both before and after 2019 that is in our pool, may or may not be in our initial pool, but doesn't go through the formal scoring process of data quality and evaluation and extraction, but we ourselves thoroughly review and extract the information from it. So it's more of about going through the formal, stepwise metrics of evaluation, which we only do for apical endpoints, really, from epi and animal tox studies. But the mechanistic studies, whether before or after our initial cutoff date, are considered as needed to support our findings. And again, that should be laid out in the systematic review protocol, but if you find that anything is unclear or we could provide some more detail, please add that to any comments.
Okay.
Yeah, thanks for that question. And thanks for the answer. This is one of the parts that's always gets questions because the systematic review is such a complicated and ever-changing thing, because you have to do your review and then you have to take a consideration additional things that come after you do the actual big data evaluation. So I really appreciate that thorough response. Dr. Rubin.
Hi, Dr. Rubin. I was wondering if you could tell us how you evaluate potential bias introduced by using industry-funded studies, and if there's a part of your methodology that prioritizes using publicly funded peer-reviewed studies. Thanks.
We do not consider funding bias as a consideration in our data evaluation. All scientific data is considered on the same level through the same evaluation metrics. There are positives and negatives to GLP studies, publicly peer-reviewed studies, and that's why we don't want to consider one over the other. They're all considered equally together.
Thank you for that response and for that question, Dr. Rubin. Are there other questions for Dr. Jacobs? All right, seeing none, thank you very much for the presentation and for answering the questions. And I guess we move to our next presentation. And that would be Dr. Sasuduran. Sorry for not getting that name quite right.
Thank you. My name is Abhilash Shashidharan, and I am a human health assessor. I'll be presenting the non-cancer hazard assessment of 1,3-butadiene. Next slide, please. Although 1,3-butadiene itself is relatively unreactive, it undergoes metabolic activation by cytochrome P450 enzymes to form electrophilic epoxides, which can alkylate cellular macromolecules and drive toxicity. Because metabolism is the primary determinant of 1,3-butadiene's toxicological profile, understanding species-specific differences in these pathways is critical. As shown in the diagram, 1,3-butadiene is initially metabolized by cytochrome P450 enzymes, producing epoxybutane, a reactive intermediate. EB can further oxidize to form diepoxybutane, an even more reactive metabolite. Detoxification pathways exist through glutathione conjugation or hydrolysis via epoxide hydrolase, leading to the formation of B-diol. Both DEB and B-diol can undergo further transformations. DEB can generate EBD and B-diol can generate HMVK. Importantly, these metabolites are highly reactive and capable of forming DNA and hemoglobin adducts. While these enzymatic pathways are functionally similar across species, quantitative difference in the production and detoxification of these metabolites results in significant interspecies variation in toxicity. Mice, for instance, demonstrate high efficiency in forming DEB, developing ovarian atrophy and hematologic malignancies even at low exposure levels. Rats, although less sensitive, exhibit tumors and other adverse effects at high exposure levels. In contrast, humans appears particularly susceptible to hematopoietic cancers. These interspecies metabolic variations provide a crucial foundation for understanding the species-specific health hazard associated with 1,3-butadiene, which I will discuss next. Next slide, please. This slide provides an overview of the key non-cancer health hazards associated with the 1,3-butadiene exposure. The comprehensive inhalation study database, primarily consisting of subchronic and chronic studies in rodents, informs our understanding of non-cancer effects. The key health endpoints identified in these studies include developmental, reproductive, and hematological effects. Several past assessments, including those by EPA's Integrated Risk Information System, Texas Commission on Environmental Quality, and Office of Environmental Health Hazard Assessment, identified ovarian atrophy and fetal weight reduction as critical endpoints. In contrast, ATSTR did not derive minimal risk levels for 1,3-butadiene due to interspecies metabolic differences and insufficient chemical specific data. The human relevance of ovarian atrophy observed in mice remains an important unresolved question. To address these uncertainties, EPA evaluated the mode of action for ovarian atrophy, initially proposed by Kirman et al. And revised by EPA by integrating all available evidence. Next slide, please. This slide shows the proposed MOA for ovarian atrophy observed in mice. The pathway begins with bioactivation of 1,3-butadiene and progress through the distribution of reactive metabolites, follicle destruction, and ultimately ovarian failure. The first critical step in this process is bioactivation. Mice metabolize 1,3-butadiene more efficiently than rats or humans, producing significantly higher levels of the reactive metabolite diperoxybutane leading compared to other species. This species-dependent metabolic activation is a key determinant in ovarian toxicity, as higher level DEB levels correlates with the greater ovotoxic effects. Once bioactivated, these reactive metabolites are distributed systematically, with the DEB accumulating in ovarian tissue. DEB has been detected in the ovaries of both rats and mice, with higher concentration found in mice. The direct exposure of ovarian follicles to DEB is a crucial step in the progression to follicular damage. The third step in this pathway is follicle destruction, primarily mediated by apoptotic mechanisms. An analog of 1,3-butadiene, vinyl cyclohexene, has been well documented to induce ovotoxicity through follicle depletion. Its dipoxide form, VCD, triggers apoptotic signaling with ovarian follicles, leading to their depletion. Similarly, DEB has been demonstrated to activate mitochondrial apoptosis in lymphoblasts, suggesting that a comparable apoptotic mechanism may underlie follicular destruction. Ultimately, a decline in follicle numbers lead to reduced estrogen production, impairing normal ovarian function and reproductive health. In addition to follicle loss, other molecular pathways, including DNA damage, oxidative stress, and inflammation, are likely to contribute to the progression of ovarian dysfunction. Next slide, please. EPA applied IPCMS mode of action and human relevance framework as outlined in Bubis et al. To analyze the human relevance of a non-cancer mode of action, specifically ovarian atrophy observed in mice. This framework addresses 4 key questions. For the first question, EPA concluded that there is sufficient evidence to establish a mode of action for ovarian atrophy in mice. To address questions 2 and 3, human relevance cannot be excluded based on either qualitative or quantitative differences between mice and humans. Fourth, while human relevance is not excluded, there are key quantitative differences in key events that must be considered when extrapolating mice data to humans. Next slide, please. Dosimetric modifications to hazard values for ovarian atrophy could potentially be applied through the derivation of data-derived extrapolation factors. Kirman et al. Attempted to derive DDF for ovarian atrophy based on surrogate measurements of blood metabolite concentrations and relative cytotoxicity. However, applying DDF approach requires a robust quantitative understanding of the mode of action, the target tissue, and relevant type of exposure response as outlined in EPA guidance. Several uncertainties persist. First, there is uncertainty in quantifying metabolite levels in humans, particularly for reactive metabolites like EBD. Second, the role of EBD identified as the primary metabolite in the mode of action is still not well characterized. Therefore, derivation of DDE is not supported. Instead, EPA concluded that ovarian atrophy observed in mice is not appropriate for quantitative use in human health risk assessment. Next slide, please. With the ovarian atrophy rolled out for quantitative risk assessment, we next evaluated other non-cancer hazard outcomes. First, maternal and developmental toxicity. Limited human evidence suggests a possible association between 1,3-butadiene exposure and autism risk. In animal studies, particularly in mice, dose-response effects have been observed, including reduced fetal body weight, skeletal variations, and malformations such as supernumerary ribs and cleft palate. Mechanistic evidence points to the involvement of epoxide metabolites in these developmental effects. Next, for male reproductive system toxicity, although no human data are available, animal studies reveal dominant lethality, reductions in testis weight, and sperm count, implicating genotoxic effects in sperm and potential male infertility. Finally, we assessed hematological effects. Human data are inconclusive. Animal data indicate dose and duration dependent decreases in hemoglobin levels and red blood cell counts consistent with anemia. Mechanistic evidence suggests that genotoxicity in bone marrow cells may significantly contribute to these hematological findings. Due to insufficient information on the mode of action and the role of specific metabolites, EPA applied default dosimetric adjustment instead of deriving data-derived extrapolation factors for these non-cancer hazard outcomes. Next step, please. Our assessment determined that acute exposure to 1,3-butadiene at human relevant levels is unlikely to cause significant adverse health effects. In both humans and animals, acute effects typically occur at very high concentration on the order of thousands of parts per million, well above normal exposure levels. When observed, these effects tend to be mild and transient, such as eye irritation or temporary difficulty focusing. Animal studies indicating more severe effects, including developmental or reproductive toxicity, generally require repeated exposure rather than a single acute event. Therefore, the agency has decided not to propose an acute non-cancer hazard value as any available options would have low confidence and less protective than the intermediate point of departure. To quantify the risk associated with intermediate and chronic exposures, let's now examine the benchmark dose modeling results for various toxicity endpoints. Next slide, please. This slide summarizes the benchmark dose modeling results used to identify points of departure for multiple toxicity endpoints related to 1,3-butadiene exposure. Beginning with reduced fetal weight, the initial BMD modeling of fetal weight as a continuous variable failed unless the highest dose was excluded. To address this, we adopted the approach from the 2002 IRIS assessment. In this method, individual fetal weights were converted to dichotomous data, where decreases below the 5th or 10th percentile were used to determine statistically significant differences from control. This yielded a BMDL of 2.5 ppm. For maternal weight gain, the modeled BMDL was 10.4 ppm. For supernumerary ribs, we observed BMDL 5 and BMDL 10 values of 2.9 and 6.1 ppm respectively. Dominant lethality, an indicator of male reproductive toxicity, produced a BMDL 5 of 4.83 ppm. Lastly, for anemia, a BMDL of 3.91 ppm was identified based on blood parameters. A key observation here is that BMDL5 for reduced fetal weight is lower than that of BMDL1SD for maternal weight gain, indicating that fetal weight is more sensitive endpoint than maternal toxicity, but all PODs are within a few-fold of each other. Next slide, please. This slide outlines a selection of POD for risk estimation. Fetal weight reduction in mice with a BMDL5 of 2.5 ppm was identified as the most reliable and sensitive endpoint for intermediate and chronic exposure scenarios. This selection is supported by robust data, consistent finding across species, and alignment with other co-critical effects. Notably, some rat studies showed similar developmental effects at higher doses, reinforcing the biological relevance of the selected endpoint across species. A total uncertainty factor of 30 was then applied, and intraspecies uncertainty factor of 10 accounts for variability within humans due to limited data on toxicokinetic and toxicodynamic differences. And interspecies uncertainty factor of 3 was applied to address interspecies differences, accounting for toxicokinetic differences and using a default value of 3 for potential toxicodynamic differences. This resulted in a proposed non-cancer hazard value for 1,3-butadiene. Next slide, please. This slide presents the benchmark dose modeling results for the key endpoint of reduced fetal weight using a benchmark response of 5% extra from a dichotomized distribution. As mentioned previously, dichotomization of data allowed the use of the more statistically appropriate nested logistic model, resulting in sufficient statistical model fit with a good visual fit and avoiding the need to exclude the highest dose. The resulting benchmark dose is within close range of the lowest dose tested as recommended by EPA and EFSA BMD modeling guidance. The use of benchmark dose lower confidence limit reduces uncertainty in extrapolating from a lowest observed adverse effect level. The ratio of BMD to BMDL is also small, indicating sufficiently low uncertainty in the modeling results. With the POD established, we will now examine the uncertainties related to the mode of action for fetal weight reduction and the challenges associated with applying a data-derived extrapolation factor. Next slide, please. While fetal body weight reduction remains the most reliable endpoint, substantial uncertainties persist about the mode of action by which 1,3-butadiene leads to these developmental effects. This slide focuses on the challenges pinpointing in the precise mechanism responsible for the observed fetal weight reductions. Kurman et al. Proposed a data-derived extrapolation factor for based on either a cytotoxicity or genotoxicity mode of action, linking fetal weight effects to maternal toxicity. However, this hypothesis currently lacks experimental corroboration as no direct key events have been established to link 1,3-butadiene exposure to fetal weight reductions. To further clarify these uncertainties, let's examine the specific data gaps that hinder our understanding. Firstly, there is limited information on how 1,3-butadiene is metabolized during pregnancy and in fetal tissue. Secondly, it is unclear which metabolite plays the primary role in fetal weight reduction. And thirdly, the relationship between the in vitro cytotoxicity data from diverse cell lines and fetal weight reduction remains unclear, especially given the complex and multifactorial nature of this developmental endpoint. Most importantly, since gender differences in hemoglobin levels have been reported, using data derived solely from adult male workers for interspecies extrapolation to female-specific developmental endpoints such as fetal weight reduction may underestimate a risk in females. Furthermore, it is important to note that the fetal weight reduction occur at lower doses than the maternal weight and other reproductive outcomes, suggesting that fetal weight may be more sensitive or mechanistically distinctive. Considering these uncertainties and poorly defined MOA, the application of a DDF for 1,3-butadiene-induced fetal weight reduction is deemed inappropriate in accordance with EPA guidance. Next slide, please. In conclusion, using the best available science and a robust systematic review approach, EPA concluded that ovarian atrophy in mice is not suitable for quantitative use in human risk assessment because mice exhibit substantially greater susceptibility to 1,3-butadiene and cross-species differences cannot be quantified confidently. Reduced fetal weight was identified as the most sensitive and robust endpoint for risk characterization of intermediate and chronic exposure of 1,3-butadiene. The available evidence does not support the derivation of a POD for acute exposures due to limited data and uncertainties associated with acute effects. There is robust overall confidence in the non-cancer POD for intermediate and chronic exposure scenarios. Next slide, please. Thank you for your attention. I'm happy to take any clarifying questions.
All right, thank you for that very detailed, nice presentation. Looking for questions from the committee now. I see they're lining up. Dr. Eastman was first.
Thank you for that presentation. I'm curious, what is actually the intermediate reference concentration that was derived? You give the point of departure and you give the uncertainty factors, but almost nowhere in the document does it actually give the number. It's actually buried in the appendix in a table, from what I can tell. But
the intermediate point of departure is 2.5 ppm, but that is, yeah, go on.
But that's not the reference concentration. That's the point of departure before you use the uncertainty factors, right?
That is correct.
So when you apply the uncertainty factors to the point of departure, then you get your reference concentration. And I'm curious why that's almost nowhere in the document.
So maybe that's a topic for discussion rather than.
Okay, sure.
Yeah, I think your point is well taken. The question about where it is and then what it is, and then if it needs to be clarified in the document, I think that can be part of our discussion.
Okay, thanks, George.
Yeah, good question.
Can I clarify? We don't do RFCs. We generally do MOEs. That the RFCs, but that's actually IRIS programs. Yeah, we don't do RFCs.
Okay, well, the equivalent. I mean, somehow there's a concentration that's the intermediate acceptable concentration. So anyway, we'll discuss that later.
Yeah, thank you for your question. We'll take into consideration.
And perhaps clarifying that is very much needed. Okay, Mr. Wright.
There we go. I had two fairly simple questions. The first one arises from one of the early slides where metabolic pathways were identified for mice and for humans, and then the associated health effect was identified for mice, humans, and rats. It was interesting that rats had a much lower response, but the metabolic pathway wasn't specified for them, and I'm curious about what it is.
Yeah, the metabolic pathways in mice, oxidative metabolism is very active, And at the same time, in rats, the hydrolysis is more active than the oxidative metabolism. And that actually make a very significant difference because of in mice, oxidative metabolism is very active, and in mice, 1,3-butadiene is rapidly converted into DEB. That's the most prominent metabolite detected in mice. But in humans, there are reports that the DEB is actively converted into EBD. Yeah, and in human, EBD is the prominent metabolite.
Okay. Okay, thank you. And I had one other one, and it arises from slide 40. If we could see that again.
Yeah.
Well, I can probably ask it without the slide. When you identified, yeah, there we go. That. Maybe there was another slide as well, but let me ask the question. It had to do with acute with effects in human males, where there was a statement that the data wasn't available. Is that because the studies have not been done, or because the studies are generally inconclusive? Because of very high exposure, thousands of ppm, even over one day, would be worth about 4 years of exposures at more relevant levels. Like the OSHA standard, for example, is 1 ppm. And even the short-term exposure limit, I think, is 5. So it's an interesting, yeah, there we go. Male reproductive toxicity, no human data available. Again, is that because the studies have not been done, or because the studies are somehow inconclusive?
There are no data available for male reproductive toxicity. I believe there are no studies available.
Yeah, okay. Okay, thank you.
I think I see Dr. Ottinger.
Yes, and my apologies. I'm sitting on an airplane. Can you hear me all right, George?
Yes.
Okay, 2 questions, please. First of all, I really appreciate your presentation and the uncertainties and difficulties that were encountered. And I wanted to drill a little bit more into the question of developmental effects or potential sensitive stages for human ovarian response. In other words, during the time when there's follicular loss peripartum, or right at the end of development, where the ovary loses a number of primordial germ cells, is there any indication that that might be a more sensitive stage, meaning that those female embryos or are, post-birth girls would actually suffer a greater loss of follicles?
First of all, ovarian atrophy is a mice-specific endpoint, and ovarian atrophy is observed only in mice. And it is well established that a particular metabolite, DEB alone, is responsible for ovarian atrophy. And as I mentioned earlier, in humans, EBD is the most prominent metabolite, and there are no data available.
Right.
Yeah.
Okay. For that stage, I mean, that's something that perhaps could be considered, along with perhaps conserved mechanisms that might actually attack some of the male gamete cells under formation. The more the primordial germ cells. And it's just a point to think about, and I understand there are no data there. But following up on that, some of the conserved mechanisms that have been observed with greater sensitivity in mice to rats might actually be similar to what's observed in some species of wildlife like birds that have a higher metabolic rate. I'm sorry for the background. And so I just wanted to kind of put that out there with the understanding that I understand there's no data such as these on wildlife species, but just pointing out that birds would have a higher BMR, which would then perhaps make them more liable or are labile to effects.
Or on their other
destinations to let them know that.
Did EPA have a response for that?
Thank you. Thank you for coming.
Okay. Dr. Gentry.
Thank you for that presentation. I just have a quick question on clarification. Can you hear me okay, George?
Yes, Ken.
Okay. Around the methods used, I wanted some clarification on when the benchmark dose modeling was actually conducted. If this was something 2002 or prior that was included in the IRIS assessment, BMDS may not have been able to incorporate nested continuous data at that time, which facilitated the need for dichotomization of these endpoints, but the more recent versions can handle that. So you can actually input the continuous data directly and model it that way. So I just wanted some clarification around the methods and if what we're relying on in the assessment is that dated.
And yeah, the BMD modeling, as I mentioned in the presentation, we initially try, and this is not IRIS data, this is actually we did ourselves. And then, as I mentioned in the presentation, we initially tried with the continuous, and we had to exclude the highest dose. And the modeling actually failed with all the doses. We had to actually exclude the highest dose. And then we actually used 2002 IRIS approach with the continuous data, like converted into dichotomous, and used that for BMD.
But we updated with the current.
Yeah. Yeah, we actually updated with the current model, yeah.
With the current what?
Model.
Oh, okay. Great. Dr. Gentry, did that answer your question?
Well, I think we can discuss some more when we get to that charge question, because I think if the model's failing with the actual data, that needs to be part of the conclusions around this data set and using it.
Okay, good. Dr. Apte.
Hello, this is Udayan Apte. My question is regarding variability in CYP2E1 levels. There is, the first step, the first key event is metabolism, which is significantly dependent on CYP2E1. And with the changing demographic, especially with obesity, as well as alcohol use disorder, both of which are known to induce CYP2E1, it is possible that certain part of the population is actually generating enough amount of the metabolite, which may not be happening in all of the people, but certain people who certainly have induced CYP2E1 levels. So when the modeling was done, or any specific considerations were given to the variations in CYP2E1 in human population.
Thank you for your comment. We didn't actually consider it, and yeah.
Okay. Dr. Santos Bourgois.
Yes, thank you very much. It was a beautiful presentation. I have two questions. One on the interspecies difference. How strong is the evidence on that on that difference? And a sequence question for that. When you use all their toxicologic data, like the one that you showed for fetal weight. Toxicology studies done in the 70s, early 80s, still the good laboratory practices were not enforced at that time. How did you assess the quality of the data that you use for those older studies?
Thank you for your question. As we explained earlier, we did a robust systematic review and confirmed that the study used for the dose response analysis very robust and high quality.
But how much do you trust that those older studies actually had good analysis of their own data, as we do now when we have audits of studies that have an external audit and check on the analysis that they did?
I see Dr. Lowett is on screen. Is the response coming from you, Dr. Lowett?
Yes, and I'm being told to smile. I don't smile very often. Anna Lowett, for those of you I don't know, Senior Science Advisor, OPPT. Appreciate the question about the data quality. And just one thing we like you to recognize is that most of the chemicals in the queue for risk evaluation at EPA's Office of Pollution Prevention and Toxics are very old chemistries. This is really not a unique situation. For those SAC members who have participated in recent meetings will understand that many of the studies and much of the data that we look at is, what you would consider dated today. And they may not meet the GLP standards. Some of them are pre-OECD guideline, et cetera, et cetera. And most of them we don't have the raw data for either. So we do have a robust systematic review approach that's been reviewed by multiple SACs and the NAS to ensure that our evaluations are consistent and transparent. But that said, it's impossible to know what happened 20 years ago. We do our best, and that's just part of the work that we do. And so you can see in our systematic review appendix, the review of all the studies, not just this one. And so we look forward to your comments on any and all of the studies. But I think our conclusion is that the studies that we are using in all aspects of our assessment to make our decision points, not only just the points of departure, are of sufficient quality for deriving risk estimates and ultimate risk management. And to answer the first part of your question, we have a lot of confidence in the difference in the species, hence our proposal that you heard from Abhi around the ovarian atrophy endpoint. Thanks.
Thank you for the question and for the response. Okay, are there other questions from the committee? I actually have one or maybe two questions. First of all, on the uncertainty factor for animals or UFA, you used a 3 instead of a 10. So what was the rationale for using the 3 versus the 10?
We have actually taken into consideration the toxicokinetic part of the yeah, that's why. So the toxicokinetic part was actually taken into consideration.
Toxicokinetic part of what? Or Dr. Lowett, are you going to try to help?
I'll try. So the typical 10x database animal to human extrapolation factor can be separated into its toxicokinetics and toxicodynamic portion. In the case of 1,3-butadiene, similar to way many of the assessments that the SAC has seen in the last year or two, the kinetic portion is being accounted for in a 3/4 body weight scaling, which is consistent with EPA guide. No,
Blood air coefficient for a gas.
blood.
Category 3 gas.
Then what? You should answer this.
Right, this is Keith Jacobs again. In this case, we've determined that 1,3-butadiene is a category 3 gas, and in accordance with several updates to our EPA guidance, we base the toxicokinetic consideration for animal to human extrapolation on blood air coefficient, which is assumed to cancel out and default to 1 between animals and humans, and therefore that toxicokinetic component of the uncertainty factor drops away. And that's why what's remaining is the 3x to account for toxicodynamic differences, which we cannot quantify.
Okay. Yeah, and I don't want to go too far down this rabbit hole. Okay, so I'm not. So on the blood to air coefficient, that's the fraction that's in the air that gets taken up by the animal. Is that what that is exactly?
It's the ratio, the relative ratio between at the border between air and blood at the alveoli, what percentage will go into the blood versus stay in the air, just based on the chemistry of the chemical. And then what's the ratio of how that works in humans versus animals. And when it's either the same or if animals are higher, we default to 1 for both. And that's why 3x drops away.
Okay, that explains it for me. So thank you for that. And I see Dr. Lowett, did you want to follow up?
I did want to follow up on a related question from a few minutes ago about the RFC, RFD, MOE clarification from a previous commenter. So as you heard from Abhi, the Office of Chemical Safety and Pollution Prevention and OPPT, we generally do not do what's called reference doses or reference concentrations, but that's a bit of semantics in that a reference concentration, a reference dose includes a point of departure adjusted for the extrapolation on uncertainty factors. Whereas in the risk assessment programs and the risk programs under FIFRA and TSCA, we do what's called a margin of exposure approach, where we essentially take those uncertainty factors and use them as what we call our benchmark margin of exposure, or benchmark MOE. So if you look through the risk characterization portion of the risk evaluation, they will, in the tables and through the narrative, will describe the benchmark margin of exposure. And that benchmark MOE is the totality of the extrapolation on uncertainty factors. So the elements of the RFC and the elements of the POD versus and the MOE approach are the same. It's just where one is, how the ratios are put together.
Okay. Dr. Johnson.
Hey, thanks. I just want to follow up on a question that you posed, Dr. Cobb, and Dr. Jacobs, maybe you can help me understand this a little bit better. You mentioned that the factor is 3 is because you understand the toxicokinetics better, and I get that. I've seen it done before, but usually there's a PBPK model associated with it, right? And you have more information than just the absorption side. You have information on metabolism and distribution and excretion. And I understand that you do have information on some of the metabolism, right? We know some of the metabolites. I don't know if we have a quantitative understanding of the metabolites, though. So please correct me if I'm wrong. Do we have a PBPK model? Because if we do, I didn't see it.
There is not. There are some PBPK models, but not anything that's considered sufficient for risk assessment. So in the absence of a PBPK model or sufficient toxicokinetic data generally to, as Avi alluded to, either do a data-derived extrapolation factor or somehow quantitatively measure that, we use our default approaches based on EPA guidance. So for an inhalation exposure where there's a systemic effect, that approach is that the difference is driven primarily by the difference in absorption into blood, that's the most important factor. So that's what drives the main difference between animals and humans, and therefore that's why the blood-air coefficient is what this adjustment's based on, and by it defaulting to be equal between rodents and humans, the uncertainty factor drops away for toxicokinetic differences. So you're right. Ideally, we would have PBK model. We do not. So we use our standard approach, which is based on blood-air coefficient being equal.
Okay, but you still have differences in metabolites between species,
Yes.
right? I mean, that was part of the presentation. So how do you
Yes.
count for those differences?
Well, as Abhilash Sasidharan presented, we are not able to confidently quantify those, and that is why we do not derive a specific extrapolation factor based on that. And I'll let him follow up more.
Yeah, there are some reports. They actually quantified the hemoglobin adduct using hemoglobin adduct data, but in the case of human, that is actually not consistent, and we only have data from male workers, and we are actually our endpoints are female specific developmental endpoints, there are like uncertainty regarding the female hemoglobin adduct data, and exposure response is not like well correlated with the female hemoglobin adduct. And yeah, there are some data and there are uncertainty as well. That's why we didn't actually use that particular data for our analysis.
All right, thank you.
Are there other questions? I saw Dr. Eastman there for a while, but maybe you decided against it.
Well, it's just responses. She did say it was a matter of semantics, but the fact that they won't tell you what is an acceptable intermediate concentration, I find quite bothersome. They say, here are the uncertainty factors. Is your level below I mean, it's we'll get to this later, I'm sure, with the acute stuff, but it's very odd to me.
I understand what you're saying 100%. Okay, are there other questions for the EPA? If not, we are a couple of minutes ahead of schedule, but not so far that we should go into the next topic, I think. But I'm going to ask our DFO, Ms. Munir, if we should take a lunch break now.
Yes, so I mean, on the agenda, it says 10 p.m. and right now it's 12:04. So yes, we can go ahead and take a 60-minute lunch break.
Great. And so let's all convene back at 60 minutes from now. I think there will be a countdown clock, but I'm not 100% sure. So check your
there it is.
screens.
Okay.
All right.
It's on
We
the-
will see you folks in an hour. Right. Welcome back to the Science Advisory Committee on Chemicals afternoon session for Tuesday. And it's customary for us to take the roll now, not for reintroductions, but just to take the roll. So I am here, George Cobb. What about Dr. Apte?
I'm here.
And Dr. Baker? No Baker. Dr. Chasen?
I'm here.
Dr. Ike is here.
Yes, I'm here.
Okay. And then Dr. Fox?
Here.
Dr. Gentry?
I'm here.
Dr. Higer Bernays?
Here.
Dr. Jenkins?
I'm here.
Dr. Merced Nieves is maybe not.
Yes, I'm here.
You
I
are
will
here.
be out from 2 to 3.
All right. Then Dr. Rubin?
Here.
Dr. Semmel?
Yes, I'm here.
See you. Mr. Wright?
I'm here.
And Dr. Santos Bourgois?
Here I am.
Dr. Roby?
Yep, I'm here.
Dr. Johnson?
I'm here.
Is Dr. McKenzie here? Says not.
I'm here.
Oh, you are here. Good.
And I'll be out from 2:15 to 4.
Okay. Dr. Fairbrother?
Yes, I'm here.
Dr. Eastman?
I'm here.
Dr. Hopkins?
Here.
And Dr. Bean Friedman?
I am here.
Dr. Finner Crisp?
Present.
And Dr. Mayer?
Yes, I'm here.
Did I miss anybody? And then I don't think Dr. Baker is going to be here today. All right. So we're proceeding on through the EPA presentations, and now we're going to hear from Dr. Huang on butadiene cancer human health risk hazard assessment. Excuse me, human health hazard assessment.
Hi, everyone. My name is Anne Huang. I'm an epidemiologist. Dr. Sashi Horong and I will talk about the 1,3-butadiene cancer hazard assessment. Next slide. The outline of this presentation includes 4 parts: evidence integration, weight of the evidence, cancer dose response assessment, and the IUR derivation for leukemia and bladder cancer. Next. First, I want to talk about the history of cancer hazards of 1,3-butadiene. EPA IRIS in 2002 published an IUR for leukemia, 0.08 ppm, which is based on an epidemiological study with male workers. This epidemiological study is called the US-Canadian styrene butadiene rubber cohort study, also called the SBR cohort study. In 2012, ATSBR concluded that epidemiological data showed occupational exposure to 1,3-butadiene was associated with increased mortality. In 2012, IARC recognized sufficient evidence of carcinogenicity only for cancers in the lymphohematopoietic system. In 2021, NTP found that butadiene is a known human carcinogen for leukemia. Since IRIS published the butadiene IUR in 2002, The SBR cohort study had multiple updates, including additional follow-up years, the inclusion of female workers, and the refined exposure assessment. Therefore, the EPA OPPT cancer assessment focuses on two things. The studies published after IRIS published IUR in 2002, and using the updated cohort data for deriving the IUR for leukemia. Next slide. EPA's systematic review identified 73 epidemiological studies and 35 animal toxicological studies. In the 73 epidemiological studies, robust evidence showed that 1,3-butadiene is a carcinogen for leukemia. Moderate evidence showed 1,3-butadiene is positively associated with bladder cancer, but there is only slight or no evidence for other cancer sites. In the 35 animal toxicological studies, 1,3-butadiene is a multi-site carcinogen with evidence in both mice and rats. A higher carcinogenic susceptibility is observed in mice at a concentration of 6.25 ppm, compared to rats at 1,000 ppm. Lymphohematopoietic cancers were only observed in mice. In addition, we also have mechanistic evidence. The metabolic activation of 1,3-butadiene produces DNA-reactive metabolites, such as EB, EBD, and DEB, that form DNA adducts, which induce mutations in critical genes and the chromosome of aberrations, ultimately driving tumor formation. Therefore, based on EPA cancer guidelines for carcinogenic risk assessment, 2005, 1,3-butadiene is considered carcinogenic to humans. In the following 5 slides, Dr. Sashihara will talk about the mutagenic mode of action, MMOA, analysis conducted by EPA.
Thank you, Anne. Now I will talk about our proposed mutagenic mode of action analysis for lymphohematopoietic cancer associated with the 1,3-butadiene exposure. As Anne mentioned in the previous slide, epidemiological studies have demonstrated that occupational exposure to 1,3-butadiene is linked to an increased risk of mortality from various lymphohematopoietic cancers, particularly leukemia and lymphoma. Furthermore, 1,3-butadiene has been identified as a multi-organ carcinogen in animal studies, most notably inducing lymphomas in mice. The underlying mechanism for these cancers is hypothesized to involve the mutagenic potential of one or more 1,3-butadiene metabolites. This hypothesis is strongly supported by several previous reviews, including those conducted by Kirman et al., NTP, and IARC. Based on this body of evidence, EPA proposes a mutagenic mode of action for lymphohematopoietic cancer caused by 1,3-butadiene exposure. This analysis was conducted in accordance with the EPA's guideline for carcinogen risk assessment and follows the draft framework for determining a mutagenic mode of action for carcinogenicity. Next, we will take a closer look at the key events that support this hypothesis. This slide outlines the proposed mutagenic mode of action for 1,3-butadiene-induced lymphohematopoietic cancer, organized into 4 biological key events. The first key event is bioactivation. 1,3-butadiene undergoes metabolic activation primarily via hepatic cytochrome P450 enzyme, resulting in the formation of electrophilic intermediates such as EB, EBD, and DEB. Following bioactivation, these reactive metabolites readily react with the DNA, forming DNA adducts. This has been demonstrated across multiple experimental systems, including in vitro, in vivo, and occupational exposure scenarios. This adduct formation disrupts normal DNA replication and DNA repair mechanisms, leading to point mutations, gene deletions, and chromosome aberrations. As these DNA lesions accumulate, they become fixed as mutations in critical genes. 1,3-butadiene has been shown to induce chromosomal aberrations and gene mutations, notably in oncogenes such as KRAS, which drive uncontrolled cell proliferation, and tumor suppressor genes such as TP53, which control cell cycle and apoptosis. Ultimately, the accumulation of these critical gene mutations drive cancer development. This progression is supported by animal studies demonstrating hematopoietic cancer development following chronic exposure, as well as epidemiological data linking 1,3-butadiene exposure to increased mortality from hematological malignancies. For example, chronic myeloid leukemia, a malignancy typically characterized by the Philadelphia chromosome translocation, a well-known driver mutation, has been reported at higher incidence among workers exposed to 1,3-butadiene. This further strengthening the link between 1,3-butadiene exposure and mutagenesis-driven carcinogenesis. Interestingly, a recent study found that DEB does not induce Philadelphia chromosome in a leukemia cell line. This suggests that other metabolites, including newly identified EB-derived bifunctional metabolites, may play a role in humans. To further substantiate these 4 key events, next we will look at specific studies examining both positive and negative findings. Next slide, please. This slide summarizes the weight of evidence supporting the mutagenic mode of action for 1,3-butadiene. Starting with bioactivation, epoxide metabolites have been detected in over 10 animal studies, with mice producing higher levels than rats. Human studies also confirm the formation of these metabolites in exposed workers. Moving to DNA damage, there is strong evidence from both experimental and human studies. 13 studies show DNA formation, DNA adduct formation, and strand breaks, and 5 out of 6 human studies detect significant DNA damage. Next, mutations. Over 15 studies have shown gene mutations, chromosomal aberrations, and micronuclei, with mice generally showing a higher response than rats. Although early human studies were mixed, more recent studies consistently show increased micronuclei in workers exposed to 1,3-butadiene. Finally, cancer development. 2 rodent studies confirm multi-organ tumor formation, and 4 or more human studies link 1,3-butadiene exposure to an elevated risk of lymphohematopoietic cancers. Next, let's examine overarching weight of evidence analysis, focusing on consistency, temporality, and dose response. This slide summarizes our weight of evidence supporting mutagenic mode of action for 1,3-butadiene-induced cancer. To establish a robust MMOA, we evaluated 3 critical factors. First, we examined consistency. Across multiple epidemiological and animal studies, we see reproducible evidence that 1,3-butadiene exposure leads to mutagenic outcomes. Secondly, temporality, which examines whether genetic damage occurs shortly after exposure and before cancer develops. Studies in animal models show that DNA adducts and mutations appear within days of 1,3-butadiene exposure. This suggests that mutagenic effects occurs early in the carcinogenic process, consistent with cause and effect relationship. Thirdly, dose response. Higher exposure levels correlate with greater frequencies of DNA damage and mutations. Considering the overall strength of evidence, the proposed MMOA is supported by multiple independent lines of evidence, including DNA adduct formation, mutations in critical genes, and clear carcinogenic outcomes. Both rodent studies and human epidemiological data align with this hypothesized mutagenic pathway. Given the strength of the weight of evidence analysis, let's now summarize our key conclusions. Next slide, please. In conclusion, our weight of evidence analysis support a mutagenic mode of action for 1,3-butadiene-induced lymphohematopoietic cancers. The primary driver for this mutagenicity is the formation of electrophilic metabolites, which lead to DNA damage and subsequent mutations. Because the evidence for a mutagenic MOA is sufficiently robust, a linear cancer assessment approach incorporating age-dependent adjustment factors to account for increased susceptibility in early life is used to derive the inclusion unit risk for these malignancies. This concludes the analysis of mutagenic mode of action analysis. I will now hand it over to Anne to present IUR derivation. Thank you.
Hi, this is Anne Huang again. So after we summarize all epidemiological, animal, toxicological, and the mechanistic data in the studies, EPA has determined that the evidence is robust for lymphohematopoietic cancers. On the other hand, the evidence for bladder cancer is inconsistent. Epidemiological evidence is moderate. Animal toxicological evidence is indeterminate, and the mechanistic evidence is slight. To select studies for cancer dose response assessment, we consider study quality, dose range, and exposure response, the strength of the evidence supporting the associated tumor type, relevance, and the uncertainties. Specifically for epidemiological studies, the evaluation criteria include study population, exposure assessment, exposure concentrations, statistical analysis, confounder adjustments, and the population risk estimates, such as relative risk. I will talk about the weight of evidence for leukemia and the dose response assessment using this criteria in the next slide. Our selection of studies focuses on human outcomes with robust and or moderate human evidence. The weight of evidence for leukemia is robust. We identified 21 leukemia epidemiological publications that provided those response results. 70 out of the 21 publications showed a significantly positive association. 18 out of the 21 publications used data from the US-Canadian styrene-butadiene rubber cohort study, also called the SBR cohort study. Next slide. Since most leukemia and bladder cancer publications with those response results used data from the SBR cohort, I want to talk about the recruitment, follow-up, and the extension of this cohort study. As you see in the table, this cohort study started recruitment for male workers in 1944. The cohort study extended the follow-up for male workers to 1998. After that, recruitment was extended for female workers until 2002. Lastly, it extended the follow-up for both male and female workers to 2009. As a result, this cohort ended in 2009 when more than 21,000 male and female workers. IRIS published an IUR in 2002 using the cohort data through 1991. Macaluso updated the exposure assessment for the cohort study in 2004. These updates included more specific exposure scenarios, verification of parameters, and the further characterized peak exposure. Next slide. Through our systematic review process, we identified 16 epidemiological publications that provided adequate dose response information. 13 of them used the data from the SBR cohort from 2002 to 2024, used the updated exposure assessment, and included both male and female workers. Next slide. Therefore, EPA used the SBR cohort data for dose response assessment. There are several significant and beneficial features to adopting publications that use these cohort data, including the study design is a cohort study with more than 60 follow-up years. Publications have regression coefficients from the dose response model. High statistical power due to more than 21,000 study participants. And the updated exposure assessment used data from more than 60 follow-up years. Next slide. After the decision was made to use the SBR cohort data for dose response assessment to ensure the best available science, EPA selected studies for dose response analysis based on four considerations. Studies used the entire cohort data through 2009 and the quantitative exposure data. The study included all male and female participants, which means 21,087 workers. The study used the updated exposure assessment from Macaluso published in 2004. The quality of the study is rated medium or high in the systematic review. Next slide. This table shows that these four publications used the SBR cohort data had significant results for dose response assessment. However, only two publications in 2019 and 2021 by Cecil Kummer met the selection criteria, which are statistical significance, inclusion of follow-up data through 2009, inclusion of male and female study participants, updated exposure assessment, and the high or medium rated quality of the study in systematic review. The publication by Cecil Kummer in 2019 was not selected because it used the work years as the exposure proxy. The publication by Cecil Kummer in 2021 used appropriate cumulative exposure assessment. Therefore, only the publication by Cecil Kummer in 2021 was selected for dose response assessment. Next slide. As explained previously, the study published by Cecil Kummer in 2021 was selected for leukemia life table analysis because of the 5 following aspects. First, it used the data from the US-Canadian styrene butadiene rubber cohort study, which includes the 2009 follow-up period. Secondly, it used the updated exposure assessment of the SBR cohort by Macaluso in 2004. Macaluso used the full data set as of 2004 while updating the exposure assessment. Third, it included all male and female participants, which are 21,087 men and women. Among these study participants, the ratio between male and female workers is about 4. Fourth, the quality of the study in the systematic review is rated median. Lastly, it provided a dose-response relationship. This study used 5 statistical models. The first 3 models included an unexposed population, but EPA needs data for dose-response analysis based on exposed population. Therefore, the first 3 models were not considered. Cecil Kummer demonstrated that the results of the 5th model, the restricted cubic spline RCS Cox regression model, provided the best fit for dose-response relationship. Next slide. So why did Cecil Kummer 2021 use the restricted cubic spline Cox regression model? We can summarize 4 reasons. First, with respect to low exposure levels. Since IUR represents the dose response association at a lower exposure range, exposure response curves at lower exposure levels can be improved after excluding exposure percent time above the 95th percentile. Second, with respect to high exposure levels, excluding exposure percent time above the 95th percentile can reduce the impact of exposure outliers. Third, considering model fitting performance, there are stronger exposure response trends when excluding exposures above the 95th percentile. Finally, considering better model fit, the RCS model showed more robust model fitting than other models. Next slide. After the RCS model results were selected, its model results, such as the beta coefficients, are used for life table analysis. This slide talks about 3 kinds of data inputs in the life table analysis. The first kind of data are population statistics, which include US age-specific all-cause mortality in 2019 among all race and gender groups, and the leukemia-specific instance from the surveillance, epidemiology, and the end results, SEER 22. The second kind of data are epidemiological data from the linear or log linear model, which include beta coefficient, an estimate of the increase in the outcome, such as leukemia instance, that results from an increase of 1 unit of exposure to 1,3-butadiene. This beta coefficient is from the Cecil Kummer 2021, which was shown in slide 63. The third kind of data input is the benchmark response, BMR, usually 1% for cancer epidemiological data. Next slide. Life table analysis yield the 95% lower confidence limit of the exposure concentration, LEC, based on BMR. That results in leukemia's extra risk, 1%, after exposure to 1,3-butadiene. We selected the exposure level that resulted in the specified level of extra risk of 1%. I want to mention some essential variables and values in the life table. For example, the life table age span is 16 to 85 years. The lag time is 0 years. The reason to set the lag time as 0 years is because various lag time of 0, 10, and 20 years showed no significantly different impacts on beta in the model. The CDC concluded the minimal latency for leukemia is 0.4 years. Next slide. We recognize that EPA issued several documents related to the development and the use of the IUR. We would like to take a few minutes to clarify what's in those memos. The initial draft IUR was derived in mid-2024 and was used to develop the draft risk evaluation, including the draft risk characterization. An error in the draft IUR calculation was identified in the document review and the clearance process. This error was identified too late in the process to revise the draft risk evaluation. However, EPA did determine that it was appropriate to correct the life table analysis. The corrected life table analysis is described in Appendix F of the draft human health hazard assessment for 1,3-butadiene and detailed in the modified life table. EPA clarified the impact that the new IUR will have on the final risk evaluation conclusion in the addendum to draft risk evaluation and the corrected life table memo for 1,3-butadiene. Next slide. As just mentioned, at the later phase of the internal review, a key component of the life table analysis was revised. The assumption is that no child exposure from the occupational setting, which initiates occupational exposure at 16 years old. The associated modifications are set exposure duration for age 0 to 15 years in column I to 0 in the life table. For exposure duration at ages 16 to 85 years in column I in the life table, the exposure duration starts at age 16. Due to the assumption of no child exposure before age 16, 2 unit risks, adult exposure only unit risk, and adult-based unit risk are derived. Based on these assumptions and the modifications, the updated data can be found in Section 8 and the Appendix F of the draft Human Health Hazard Assessment for 1,3-butadiene. Even though these assumptions and the modifications were made to update the life table analysis, I want to clarify 2 critical points. The modified general population IUR did not change after rounding. Second, neither occupational nor general population risk estimates are expected to change because of the corresponding updates to exposure assumptions. Next slide. The last step of IUR derivation is using the life table analysis output to calculate unit risk UR and IUR. As the equation shows, UR is calculated by dividing the BMR by the LEC. The UR definition is the upper bound excess lifetime cancer risk estimated to result from continuous exposure to 1,3-butadiene at a concentration of 1 microgram per cubic meter in air. The BMR means the benchmark response of an adverse effect. Based on biological and statistical considerations, BMR is 1% for most cancers when using epidemiological evidence. The LEC 01 is a 95% lower confidence limit of the exposure concentration associated with a 1% increased risk. After understanding the definitions of each variable in the equation, IUR can be obtained by dividing 0.01 by the LEC. After UR are calculated, we were able to calculate lifetime IUR. Due to the mutagenic mode of action, MOA, age-dependent adjustment factors, ADEFs, are applied to adult-based unit risk to obtain IUR for the general population, because ADEF accounts for increased susceptibility to mutagens for children in the absence of data in the younger life stages. Next slide. This table shows the incorporation of the ADEF with the adult-based unit risk to obtain the IUR for the general population. The ADEF at different age groups have different values. For ages from 0 to 2 years old, the ADEF is 10. For those aged from 2 to 16 years old, the ADEF is 3. For those aged from 16 to older years old, the ADEF is 1. These values are from the 2005 guidelines for cancer carcinogenic risk assessment. 0.0062 in the table is the adult-based unit risk. As the table shows, we multiplied this ADEF with the adult-based unit risk and then summed up the adjusted partial lifetime IUR across all age groups. The IUR from 0 to 78 years old is 0.0098 per ppm. Next slide. This table shows the updated results of IUR derivation for leukemia. The updated IUR for the general population is 0.0098 per ppm. The updated UR for workers is 0.0049 per ppm. Next slide. Now we move to the bladder cancer. This slide describes the weight of evidence for bladder cancer. Systematic review identified that 7 publications investigated bladder cancer with exposure response assessment. 2 out of 7 publications showed a significantly positive association. And these 2 publications used data from the same US-Canadian styrene butadiene rubber cohort. Bladder cancer case numbers are small in the cohort. An important note is that smoking is a risk factor for bladder cancer, but smoking was not adjusted for in the dose response model. However, an occupational study published by Blair in 2007 showed that tobacco-adjusted relative risk rarely differ appreciably from unadjusted estimates for studies of occupational exposure and lung cancers. For the animal toxicological studies, there is no increased risk, instance of bladder cancer in mice or rats. In terms of mechanistic evidence, our MMOA analysis is based on leukemia. Mutagenicity may also apply to other tissues. However, no mechanistic studies were found for bladder cancer. Next slide. This slide describes the study and the model selection for bladder cancer. The study published by Cecil Kummer in 2021 was selected for bladder cancer. EPA used the same study selection process and had the same consideration as leukemia. This study has 5 statistical models to develop dose response relationships. Model 4, the exposed person time, excluding unexposed population model, was selected due to several reasons. The model included the exposed population. The model showed a significant trend. The first 3 models included an unexposed population, but we need data for dose response analysis based on the exposed population. Therefore, EPA did not consider the first 3 models for dose response analysis. The p-value for the trend in model 5 was not statistically significant, so model 5 was not considered. Next slide. The life table analysis for bladder cancer used the same process as leukemia. In the initial life table analysis, lag time was set to 20 years based on the evidence in the literature. However, bladder cancer latency was changed from 20 to 0 years in the updated life table analysis because the model that the EPA chose to adopt the beta coefficient for life table analysis used the lag time of 0 years. And the modeling of various lag time in exposure showed little effect on the beta coefficient. Next slide. Overall, the life table analysis and the IUR derivation for bladder cancer used the same method as leukemia. This table showed the summarized results of the life table analysis. General population IUR is 0.0045 per ppm. Chronic occupational UR is 0.0022 per ppm. Due to uncertainty in the weight of evidence, unit risk and IUR for bladder cancer were not combined with UR and IUR for leukemia, respectively. And the bladder cancer information was not used for risk estimation. Next slide. In conclusion, EPA OPPT is using the best available science from epidemiological studies from 1996 to 2022 to update the 1,3-butadiene IUR. 1,3-butadiene is considered carcinogenic to humans because of strong epidemiological evidence for leukemia and the moderate epidemiological evidence for bladder cancer. The proposed IUR for leukemia is 0.0098 per ppm for the general population, and the UR is 0.0049 per ppm for workers. Although we calculated additional IUR and UR for bladder cancer, we did not use the bladder cancer values for risk characterization because of uncertainty in the weight of evidence. Bladder cancer case numbers are small in the cohort, and the smoking was not adjusted for the dose response association in the statistical models. Next slide. Thank you for your attention. We look forward to your input.
Great, thank you for that presentation. And now we can move to the committee to see if there are questions. Dr. Eastman.
Thank you for the presentation. Can you comment about the subtypes of leukemias and lymphomas that we're seeing and how those have changed over time? I know there's some argument that for analyzing things by specific subtypes of leukemias and lymphomas rather than by combining them.
For leukemia, we consider all types of leukemia. I know that there are different risk estimation for different subtypes of leukemia, but we combined all of them, all of the data. So we didn't separate the subtypes. And for bladder cancer, we also consider all types of bladder cancer.
So it's my understanding that early on there was a strong association seen with chronic myeloid leukemia and butadiene, but I'm guessing that that is diminished over time because it's never mentioned again in the subsequent analyses. Is that correct?
For that type, I understand that some subtypes are significant and some subtypes were not. But Cecil Kummer, I think, published a paper in, I forgot the exact years, but I think in 2016 or 2018. After combining all the subtypes, it becomes significant. But for that specific type, I will provide that information to you later on, if that's okay with you.
Well, thank you.
All right, Dr. Fox.
Hi, yes, Mary Fox here. Thanks so much for walking us through that. And initially looking through the documents, it got very confusing with the realization of the error and then the correction. So I appreciate that was very nicely laid out. So I appreciate that. But I guess a clarification question. So you described so I'm talking about the leukemias, right? So the general population IUR was developed from the occupational unit risk plus the age-dependent adjustment factors. Was there also a scaling done for life years?
Can you please provide more information about scaling?
So yeah, so I'm remembering something from my reading, but I may have things out of place. So I think I remember reading that that there was also a scaling factor applied to the unit risk of like 78 over 62 or 62 over 78, whichever way the ratio goes. Yeah, and I don't remember seeing that in your slides as you went through. So I just wanted to check whether I'm remembering things correctly or not.
Yes, I mentioned that we calculated the adult exposure only unit risk first, and then we have to transform that data to become adult only unit risk. And then after that, we use the adult only unit risk to incorporate ADEF. So I mentioned that probably too fast. So is that your question?
Well, so that is that where the scaling, was that a scaling issue, the life years issue, or?
Can you please hold on a second?
Yes, one moment while she goes ahead and confers with her colleagues.
Yeah, and we can also, you know, follow up on this if we need to.
Can you please go to the slide 72? Sorry, 69. Maybe this slide can explain better. Next slide, please. So
It's not this one. It's the one we have the table.
Is it this one? Next slide. 68.
68.
68. Slide 68. Well, actually, we needed. Okay. So can I provide you the slide number later and go through the calculation again? Because we are trying to find the slide number.
Okay, sure.
Yeah. Sorry.
Yeah, that'll be fine, and we can either circle back to that soon today or when we get to this in the charge as well. Either one. Okay, Dr. Santos Bourgois.
Yes, Carlos is fine. Just a comment to Dr. Eastman. There is an update on this cohort published in 2022 by Valdez, where they have the different cell types of leukemia. So you can look at that paper for that question. Now, my question is on the selection between the 5 different statistical models, one for leukemia and one set of 5 equations for leukemia and one for for bladder cancer. Your criteria is different from leukemia when you choose the Cox-Splines model, and for bladder you go into the 4th model. Can you expand why? It's not clear for me your selection criteria for these models.
The criteria are all the same, but the reason we choose different models are because for the bladder cancer, the model 5 was not statistically significant, so we choose model 4. And for the leukemia, model 5 has better performance in terms of the dose response relationship. And also there are some beneficial features of that model. For example, when they restricted the data distribution to 95%, that excluded outliers. So the criteria are the same, but it's the only reason was the main reason was because of the statistical significance of the model.
Okay, so for the trend, the trend was not significant for that one, but in the first one, in the case of leukemias, why this model that excludes the unexposed?
Yes, so because the purpose for deriving IUR is for the dose response association between exposure, 1,3-butadiene exposure, and the health outcome, which is leukemia. So if the publication actually ran a sensitivity analysis, and they found that if we include unexposed population, then that will induce confounding effects for the dose responses relationship. So that's why we specifically focus on exposed population only.
Okay. Dr.
We also
go ahead.
Oh, and then we also added a charge question about that.
Okay, thank you. Dr. Rubin.
Hi there. Hi there. Thank you for your presentation. I just had a question about the evidence reviewed for breast cancer, and I saw the studies listed on page 132 of table appendix A5. And there are actually a couple of studies that have come out that came out in 2024, one of which showed significant associations with breast cancer for multiple subtypes and overall. And another study, which was a list of breast cancer relevant chemicals, which 1,3-butadiene appeared on. So I just wonder if it's at all possible to consider those additional studies.
Can you please provide the study information, and we will take those studies into consideration.
Wonderful, thank you.
Right. Yeah, that'll be good information for the EPA and their refinement of this draft risk evaluation. All right, are there other questions from the committee? I actually have a couple, and maybe I misunderstood this, but did EPA, did I hear you say that EPA set an extra cancer risk threshold for this at 1%, or did I mishear that?
BMR, the benchmark response is 1%. Usually that value is selected based on the epidemiological data.
So that's for setting the benchmark.
Yes.
Okay. All right. That's good. And yeah, I kind of misheard that. That's what it is. And my second question is a little bit picky, but it's very important in the way the document is written throughout. And this is the first time I see it. So I'll ask the question here. You talk about an LEC that's a 95th percentile of exposures. And I'm not sure that's correct. And I want to ask you, is that a 95th percentile of the individual possible exposure universe, or is that a 95th percentile of the mean exposure?
So that's not mean. That's a 95% confidence limit of the exposure concentration
And
associated.
okay, and then can you point me to where that data set or where the statistics are that demonstrate that?
So that's listed in the life table, and I think it's in the document 30 for life table.
Document 30, what document?
In give them the link. So can I provide you that file? Actually, that file is already posted for the public, but I can.
It's numbered 30 in the docket. Is that what you're saying?
Yes.
Okay, that I can find it then. Thank you. That will be very helpful.
And this is Ali Munir. I can assist in helping distributing that document to you, Dr. Cobb, as well.
Thank you,
as the
Ali.
DFO.
Yeah, thank you. But if it's in the docket as document 30, I can find it. That's
okay.
But thank you for that offer. I think that's all of my important comments. So, or questions. Let's move on then to our next presenter from EPA. And I got to find my place. It's the Consumer and General Health Population Exposure by Kit Lee.
Thank you, Dr. Cobb. Good afternoon, everyone. My name is Kit Lee. I'm an exposure scientist under the Office of Pollution Prevention and Toxics, and I'm the other co-lead assessor for the 1,3-butadiene draft risk evaluation. And I'll be presenting the general population exposure assessment and analysis, which is related to charge question number 2. Next slide, please. So this presentation is primarily based on the draft general population exposure assessment technical support document, which is a standalone document that's related to sections 5.34 of the draft risk evaluation. In addition, other supporting documents are listed here, including other technical support documents and supplemental files. Next slide, please. Here's the 1,3-butadiene risk evaluation document map. To support charge question 2, this presentation will cover the boxes highlighted in blue, which are the general population exposure assessment technical support document and the human health risk characterization found within the draft risk evaluation. Next slide, please. The environmental exposure assessment and analysis presentation from earlier today explained the justification for a qualitative assessment of the water and land exposure pathways. Reasons included low releases to water and land, high frequencies of non-detects in the monitoring databases, and limited persistence and mobility within those media. However, based on physical chemistry and fate properties, 1,3-butadiene is expected to be present in ambient air in a gaseous phase. However, it's not expected to undergo air deposition or long-range transport due to a low KOA and relatively short half-life. Monitoring studies conducted within the US and other countries have reported 1,3-butadiene in their air sample measurements. The EPA's Ambient Monitoring Technology Information Center, or AMTIC, Air Monitoring Archives, which houses data from over 6,000 monitoring sites for hazardous air pollutants across the United States, provide evidence of 1,3-butadiene being present in ambient air monitoring samples. Lastly, 1,3-butadiene is released to the air, and these releases have been reported to the Toxic Release Inventory, which are facilities regulated under TSCA. Next slide, please. Based on these key points, EPA conducted a quantitative analysis for general population exposure and risk from inhalation of 1,3-butadiene in ambient air, resulting from facility releases, which is visually represented here in this figure. Next slide, please. In order to assess the ambient air exposure pathway for the general population, EPA used a tiered approach, starting with the Integrated Indoor-Outdoor Air Calculator, or IIOAC, which is an Excel-based screening tool that uses AirMod, which is an air dispersion model developed by the American Meteorological Society and EPA that's capable of modeling air concentrations and deposition based on facility and area sources. Please click for the animation. Here in the circles of the IOEC conceptual model diagram highlights the model inputs for facility sources, which are the stack and fugitive facility release sources, along with user inputs for emission release patterns, chemical parameters, and source and location parameters. The IOEC model outputs modeled outdoor ambient air concentrations by distances away from the facility release sources. Next slide, please. EPA used the toxic release data set from the 2016 to 2021 reporting years for the IOEC modeling. There were a total of 225 reporting facilities included in this data set. The default IOEC model parameters for fugitive and stack releases were used as recommended by the user guide, also shown here in Table 2.1 from the General Population Exposure Assessment Technical Support document. EPA made conservative assumptions that facility releases were modeled across 24 hours a day, 365 days a year. IOEC model uses meteorological data from 14 stations and has two settings for the land use, urban and rural. The South Coastal Meteorological Station located at Lake Charles, Louisiana, and the rural land use setting were chosen in this screening assessment because these selections were considered the most conservative options and tend to result in higher modeled air control. With the selection of these default parameters and conservative assumptions, IOEC is considered an initial screening level approach. Next slide, please. IOEC models ambient air concentrations at radial distances between 100 to 1,000 meters away from releasing facilities. At each of these distances modeled, IOEC outputs the 95th percentile and the mean ambient air concentration from each releasing facility. The 95th percentile results for ambient emissions across all facilities in the 2016 to 2021 reporting years and distances range from 0 to 109.5 micrograms per meter cubed, with model concentrations tending to be higher at 100 meters compared to 1,000 meters. EPA also made the conservative assumption that individuals living within 100 to 1,000 meters from releasing facilities are exposed to these modeled ambient air concentrations 24 hours a day, 365 days a year over a lifetime. Therefore, exposure concentrations were assumed to be equal to the modeled ambient concentrations. Next slide, please. Using the model exposure concentrations, EPA was able to calculate both non-cancer and cancer screening risk estimates. For non-cancer screening risk estimates, EPA calculated the margin of exposure, or the MOE, using the modeled exposure concentrations and the non-cancer chronic human equivalent concentration of 5,500 micrograms per meter cubed, and the benchmark of 30, which were presented by the human health hazard team. Margin of exposure is the human equivalent concentration divided by the modeled exposure concentrations. If the margin of exposure is below the benchmark of 30, there is potential human health risk of concern, and EPA would proceed with further refinement of the screening level analysis. Across all 225 facilities from the 2016 to 2021 TRI reporting years, none of the margin of exposure calculations were below the chronic non-cancer benchmark of 30. Based on these results, further refinement was not conducted. Next slide, please. For cancer screening risk estimates, EPA estimated lifetime excess cancer risk using the inhalation unit risk and modeled exposure concentrations from each facility. The IUR, which was previously presented by Dr. Wong, was 4.4 times 10 to the negative 6 risk per microgram per meter cubed. And the benchmark for general population for excess cancer risk is 1 in a million to 1 in 10,000. If the calculated lifetime excess cancer risk is above 1 in a million, EPA would proceed with further analysis. Based on the 95th percentile model concentrations, lifetime excess cancer risk for 1,3 betadiene in the screening assessment ranged from 0 to 4.9 in 10,000, with the highest estimates at the 100-meter distance. Based on the 95th percentile model concentrations, 132 of the 225 facilities resulted in estimated screening level cancer risks above 1 in a million benchmark, and 128 facilities based on the mean model concentrations. Based on these results, EPA proceeded with further refined analysis in the next step of the tier approach. Next slide, please. As a refined approach to modeling ambient air concentrations, EPA used the Human Exposure Model, or HEM, which, like IIOEC, uses the air mod dispersion model. However, HEM uses localized regional data for meteorological and land use settings, and if available, modified user inputs and parameters for more refined modeling results. The Human Exposure Model is capable of providing model concentrations at greater range of distances from the release point, anywhere from 10 to 50,000 meters compared to IIOEC's 100 to 1,000 meters. In addition, using the US Census data, the Human Exposure Model can model concentrations and estimate risk at census blocks and provides both the population count and demographic information for those census blocks around the facilities. The figures on the right contrast the 14 meteorological stations included in IOEC's model compared to the over 800 meteorological stations included in the Human Exposure Models library. This increased granularity of meteorological and land use data in the Human Exposure Model provides geographically refined results based on the facility release coordinates. And with using the Human Exposure Model, incorporating census block data allows EPA to model ambient air concentrations and estimate risk for actual populations that are living near facility releases. Next slide, please. Same 2016 to 2021 toxic release inventory data set was used for the HEM modeling. The stack and fugitive parameters also remain the same as the IOAC screening level, but for HEM, the days of operation for the input values were specified to each facility as they reported to the toxic release inventory. And as previously mentioned, localized meteorological and land use data were used based on the facility release coordinates. Next slide, please. The Human Exposure Model produces two sets of model results: ambient air concentrations at radial distances from the releasing facility and ambient air concentrations at census block centroids around the facility. Similar to the IOEC model, HEM produces model concentrations at radial distances anywhere from 10 to 50,000 meters compared to IOEC's 100 to 1,000 meters. And at each of these distances, the Human Exposure Model results with the 95th, 50th, and 10th percentile concentrations. The other sets of results is HEM also produces results based on the census blocks within 50,000 meters around the releasing facilities. For the first 3,000 meters, HEM models explicitly for those census blocks. And then for census blocks located between 3 to 50,000 meters away, it uses mathematical interpolation. And it models and estimates a single risk value at the center of each of those census blocks. In addition, the Human Exposure Model aggregate risk estimates at each census block if there's more than one facility within that 50,000 meter distance. Next slide, please. The Environmental Release Technical Support document includes releases from the National Emissions Inventory, or NEI database. EPA conducted a targeted sensitivity screen using the National Emission Inventory 2017 and 2020 release data. EPA published a memo titled 1,3-butadiene TRI and NEI Risk Estimate Comparison Analysis to the docket on March 3rd. This memo describes the initial targeted sensitivity screen, which used NEI release data as emissions input. NEI release data included facility-specific details such as stack height, diameter, temperature, and exit velocity, as well as fugitive area dimensions and angles, allowing for facility-specific input parameters to be used in the human exposure modeling, along with, if available, individual emission unit-specific latitude and longitude coordinates, which allowed for refined spatial modeling results. This granularity of facility-specific data from NEI allowed for further refinement of model ambient air concentrations and risk estimates, especially for facilities that reported to both TRI and NEI. Next slide, please. In efforts to provide context for the modeling results, EPA evaluated 1,3-butadiene ambient air concentrations for monitoring data. EPA evaluated the ambient air monitoring data from EPA's Ambient Monitoring Technology and Information Center, or AMTIC, air monitoring archives, which houses, again, records from over 6,000 monitoring sites for hazardous air pollutants. EPA pulled results for data collected for the years January 2016 to December 2021 to be consistent with the TRI reporting years that we modeled. The 1,3-butadiene monitoring data included over 55,000 24-hour sampling entries across 12 monitoring programs. The 24-hour monitor concentrations ranged from 0 to 122.8 micrograms per meter cubed, with the highest 24-hour monitor value was recorded in Port Neches, Texas, which is along the Gulf Coast. The monitoring data indicates the presence of 1,3-butadiene in ambient air, which supports the decision to conduct a quantitative assessment for the ambient air pathway for general population exposure. For more information on the studies and the monitoring data evaluated, please see the draft environmental media concentration technical support document. Next slide, please. EPA compared the model concentrations to the available monitoring data. Overall, the ranges of the model and monitoring data concentrations were similar and had similar maximum concentrations, with 100 micrograms per meter cube for IOEC, 80 micrograms per meter cube for the human exposure model, and 122 micrograms per meter cube for the AMTIC air monitoring station. But if you look closer, please click for the animation. You can see that there's a difference between the distribution when looking between the 25th to 75th percentile. When comparing IOEC to the human exposure model, the refined model concentrations with HEM showed a tighter distribution among lower concentrations. And when comparing the distributions between modeled and monitoring concentrations, the AMTIC monitoring data was skewed to the lower end of the distribution. Now, EPA acknowledges that modeled concentrations and monitoring data are not directly comparable. Model concentrations presented here are based on the releases from the toxic release inventory and are modeled at specific distances from the facilities and do not take into account atmospheric reactions of 1,3-butadiene or other sources of 1,3-butadiene. On the other hand, monitoring data are actual recorded concentrations at a specific location, time, date, and current weather conditions. Monitoring data also includes all sources of 1,3-butadiene, but does not distinguish between the contributions for each of those sources. Next slide, please. In conclusion, EPA used a tiered approach to assess the ambient air pathway for general population exposure to 1,3-butadiene from facility releases. Using the toxic release inventory 2016 to 2021 release data, EPA used the IOEC model as a screening approach to model air concentration and estimate non-cancer and cancer screening risk estimates for potentially exposed populations within 100 to 1,000 meters from facility releases. Based on the screening risk estimates for non-cancer effects, further refinement was not conducted. Based on the screening risk estimates for cancer, EPA further refined analysis to model ambient air concentrations using the human exposure model, using modified user inputs and localized meteorological and land use data. The human exposure model provided results at greater radial distances and also estimated cancer risk at census blocks around the facility. Next slide, please. Monitoring data from EPA's AMTIC database indicates the presence of 1,3-butadiene in ambient air, which supports the decision for a quantitative assessment. Comparing the modeled concentrations to air monitoring data show that the concentrations are within the same order of magnitude overall, but that the distribution of monitored data is skewed among lower concentrations than modeled concentrations. EPA is seeking feedback on the approach and methodology of using IOEC and the human exposure model for modeling ambient air concentrations to inform both non-cancer and cancer risk evaluations. EPA is requesting feedback and suggestions on how to better incorporate monitoring data to bolster the draft risk evaluation. Lastly, EPA acknowledges that the release data from the 2017 and 2020 National Emissions Inventory may provide refinement and provided a sensitivity analysis comparing TRI and NEI risk estimates, and is currently evaluating the NEI data for inclusion in the final risk evaluation. For more details, please see the draft general population exposure assessment and the draft risk evaluation for 1,3-butadiene. And that concludes the presentation for general population exposure.
Thank you for that very nice presentation. I see some hands going up. Dr. Fairbrother.
Yeah, thanks for that. Could you just remind me when you're doing the modeling At what elevation above ground level is that modeled?
Thank you for your question, Dr. Fairbrother. I believe the human exposure model, if I'm not mistaken, the receptors being modeled are at 0 meters, so directly on the ground.
Okay, but your and then your ambient monitoring is usually like 3 to 6 feet above ground. Is that right?
That is, I believe so, yes. I've been to a few monitoring sites and they tend to be around 3 to 4 feet off the ground.
Okay, thanks.
Thank you, Dr. Fairbrother.
Dr. Hopkins.
Thank you for that. I did have a question about the inclusion years used from the emissions input. Just in my experience, we found that the COVID years are not representative, and I wondered if you had looked into that.
Thank you for your question, Dr. Hopkins. I'll need a moment to confer. Yes, I'll need some time to confer with a colleague when it comes to the release assessment for 1,3-butadiene. We did include the 2020, 2021 years, but we'll have to double check how much of an impact COVID had on those releases. Thank you for your question.
And if it's possible to have that information when we get back to the charge question later in the week, that would be really helpful. Even if you don't have a full analysis, if it's, is there any more information on that? That would be very helpful. Appreciate it. Dr. Chason.
Thank you, Dr. Kopp. I have 2 questions, but I wanted to start with a recognition that the kind of assessments and models, et cetera, that have been developed over the years by EPA to take a look at community and consumer general population exposures is really been, I think, tremendous advancement. So I think we ought to recognize the improvement in science, at least the ones that I've been aware of over time. Having said that, I have one comment, and then I want to revive the question that I asked earlier. Let me start with that. It has to do with the statement about that for consumer products there's no butadiene. I think EPA said bluntly there's no butadiene in 1,3-butadiene in plastics and rubber, and that may well be. But are there actual studies which actually measure over time and different conditions such as temperature, possible release from those kinds of medium, in addition to air monitoring around it? But I mean, actual studies like something done at NIST, I didn't see that kind of evidence. The other, and the comment that I have is that I brought this up before, and 1,3-butadiene might not be the most relevant chemical to, if you will, be worried about for this condition. But in today's, in the way I understand TSCA, you have to go from the beginning of the use of the chemical in industry to the consumer and disposal. And in between those 2 points are, I think, some increasingly overlooked elements of distribution of products, and which relates to potentially environmental contamination. And that is these increasing number, massive product distribution centers, which take incredible volumes and mass of materials in. It's handled and it's released. Has EPA, do you know, I mean, considered that as a point of it's not industrial, but it's certainly a distribution point that could be modeled very much the way you've talked about modeling from the industrial centers. I mean, I think there's a lot of analogy there. Can you speak to that?
Thank you for your question, Dr. Chason. I'll need a moment to confer for that.
Certainly. Thank you.
While we're waiting, I'll just say, Ms. Jenkins, you'll be next on the docket for a question. And anybody else that wants to ask a question, please raise your hand.
Hi, Dr. Chason. Yeah, I think some of the questions, parts of your questions kind of intertwine with occupational. So I'll have to confer with the lead assessment on occupational, and we'll try to provide an answer for that question.
Okay. The general population exposure comes in as these big, huge buildings are vented. So there's, I mean, either if the chemical is off-gassing in any way, or combinations, it's either staying in the building or it's being distributed to the immediate residences. And a lot of these places are in either public areas or they're in areas where there is nearby residents. So this gets back to the concept of a fence line community type of scenario, and very much to the models that you're talking about where you have certain distances. So this is both a worker as well as a general community contaminant issue.
Yeah.
Thank you.
So we can come to that as a part of our discussion later,
Okay.
Dr.
Fine.
Chason. I see.
Thank you.
Dr. Denisio?
I was just about to say the same thing, Dr. Cobb, that I appreciate all the comments Dr. Chason is providing, and it sounds like a lot of feedback that would be really helpful for us as part of the response. So thank you.
All right, Ms. Jenkins.
Thank you. Thank you for the presentation. I did notice there was a mean value that was used of 0.091 micrograms per cubic meter. And I just wanted to understand if that was a mean of all the data over all the years or the monitoring data.
Sure. Let me check back with the monitoring data slide. Which slide number was that? Slide 93, please. Are you referring to the mean of?
Yes, the AMTIC, the mean
AMTIC
data.
Yes.
Yes.
So yes, that was the mean concentration value for the entirety of all of the monitoring data that we collected. So the 24-hour monitoring samples that were collected for 2016 to 2021 from the AMTIC air monitoring archives.
Okay. Okay. And that leaves, how were the non-detect values considered in that? I know in one of the graphs it showed some with no, means with no non-detects removed, but this
right.
would.
Yes, so for the monitoring data here, we did not include the non-detects. These were all just samples that had the detections that reported above the reporting limit.
Okay.
So good information. I'm sorry.
The other thing. Oh, go ahead. I'm sorry.
No, I was just saying continue, please.
Oh, the other thing, you mentioned that high value detected at Port Neches. I looked over the last couple of days, and I've not been able to find that value. It looks like it was detected in 2021, but I was not able to confirm it. And so I just wanted, the next day or two, if y'all could confirm that, that concentration.
Sure. We can definitely.
I
look
also
into
wanted to, oh, go ahead.
Oh, I was going to say, we provided the raw data set that we collected
Yeah.
from the air monitoring aquifers. We
I didn't
posted
see
on the
it there
docket
either.
as one of the supplemental files.
Right. I looked
Okay.
there, I didn't see it, and then I went to our database in Texas, didn't see it there either. So I just wanted to make sure. I mean, there's a value that's close, but it's not exactly that. So I just wanted to make sure that was calculated correctly. The other thing is, you know, in Texas, we have a huge monitoring program that I talked about, I think, the last assessment. This includes, you know, AMTIC doesn't include all of our monitors, stationary monitors. We have approximately 44 canister monitors that all of those are looking at butadiene. We also have 45 continuous auto GC monitors that are measuring butadiene 24/7 every year. So we have this huge database, and some of these monitors go back decades that could be useful in this type of evaluation. Instead of looking at a modeled concentration and average and comparing it to a 45-minute concentration, I mean, a 24-hour concentration, looking at annual average concentrations, we calculate those every single year and do evaluations on butadiene. So I would just encourage EPA to contact states. I'm sure we're not the only one that does that, but we have a tremendous amount of data and monitors, and some monitors are very close to facilities. I looked at just 2 yesterday that Dr. Hopkins is aware of. 2. We also have one Groves that's very close to a facility in our Beaumont region. So I really urge EPA to work with states. We also have industry monitoring networks that we evaluate their data as well. And so I think it's an important data gap that's not being, or important source of data that's not being fully utilized here. Thank you.
That's a great comment, and I'd like to echo that assertion that perhaps EPA can get lots more information by cooperating with states to get this kind of information, not necessarily from Texas only, but I'm sure other jurisdictions have this type of information. I would like to follow up really quickly on that last slide, then slide 93. We don't necessarily have to pull it back up since it just came up, but there was a mean reported that was well above the 75th centile of the data distribution, and that has to be an arithmetic mean, doesn't it? Not a geometric mean.
Arithmetic mean. Oh yes, that was an arithmetic mean.
Okay, it might be, even though it sounds mundane, might be good to put that in the report, but that can be in my comments too. Yeah, I'm always suspicious of arithmetic means that are outside those bounds. And then we have a comment. Oh, Dr. Dionisio?
Yeah, can I just add one follow-up to the previous discussion we were having about additional data from states?
Surely.
I'd just like to put in a request that if the SAC members know of specific data sets or resources, et cetera, to please submit that, or include that as part of the response, submit it to the docket. That would be really helpful for us.
That's excellent. We will do that. And also, some of these comments are for not just this particular assessment, but for others as well. All future
Absolutely. Yes, absolutely. Always submit whatever you know of to the docket.
Well, it's to get it for EPA to get it before we get to this point.
Yes,
but that's
definitely.
part of the comments, not part of the questions.
Yes. Thank you.
Okay, great. Thank you. Dr. Santos Bourgois.
Yeah, thank you very much. A very nice presentation. I understood many things that before I didn't understand. Just one quick question. What stopped you to include NEI data before? Or are you referring to the 2023 report or what?
Thank you for your question, Dr. Santos Bourgois. I'll need one moment to get clarity on that. 1 second.
Hi, this is Kathy Denisio. Can you clarify, are you asking why the NEI data was not included in the initial analysis? Yeah, so the analysis that was conducted was a screening level analysis initially with the TRI data. And we were able to, after the draft was published, work with some of our colleagues to incorporate some of the NEI data into a sensitivity analysis, which is what you saw published as an addendum. So we're currently evaluating that data for inclusion in the final risk assessment.
Okay, thank you.
Thank you.
Yeah, great. Thank you for this the question and the response. So are there other questions? If not, thank you for that great presentation. I really appreciate it. And also the question and answer. It was very helpful for me, and I hope for the rest of the committee. So thank you very much. Now we are moving to our next presentation. That would be the occupational exposure assessment, and that's going to be presented by Ms. Taylor.
Actually, Dr. Cobb, there's a brief transition to consumer exposure.
You know what?
It's listed in the agenda as, yeah, sorry. Great.
Yes, consumer, it was all the same in my agenda, but this is fine. Yeah, please proceed.
Thank you, Dr. Cobb. I'll briefly transition into the background for charge question 3, which is focused on consumer exposure. So according to the 2016 Chemical Data Report database, the use of plastic and rubber products, including synthetic rubbers, were identified as consumer conditions of use for 1,3-butadiene. Based on product searches and data identified from systematic review, EPA determined that 1,3-butadiene is a monomer that's used to create polymers for consumer products. These polymers include, but are not limited to, acrylonitrile butadiene styrene, or ABS resins, as well as styrene butadiene rubber. These polymer-based products are considered stable and not expected to degrade or depolymerize into the 1,3-butadiene monomer. In addition, residual 1,3-butadiene concentrations in polymers and other products are very low or often not detectable or reported. Safety data sheets, use reports, and the products list that were available to EPA do support that consumer exposure assessments show very low concentrations of 1,3-butadiene in these products, often less than 0.1%. Some products listed 0.04 parts per million. Based on this, EPA conducted a qualitative assessment for the consumer exposure and does not expect exposures to the 1,3-butadiene monomer. And that concludes the qualitative assessment done for the consumer exposure assessment.
All right. So are there questions from the committee? Dr. Chason.
Thank you. I think this is where my question about the NIST type of studies on the polymers and the evacuation, from and under what conditions. So that question I asked before is probably better placed here for you to consider.
Yes, thank you, Dr. Chason. So as I previously presented, we didn't have any additional data to support an assessment of the residual 1,3-butadiene monomer in these consumer products. If the SAC has any data that can support alternative analysis, we welcome that as part of your response to the charge question.
Okay, well, we can go into that during our discussion. Chris, did you have your hand raised again, Dr. Chason? Okay, if there are no other questions, then I think we can move to our next presentation on the occupational exposure. And this is by Ms. Taylor.
Nope. It's just putting my video on.
Yes, it is on. We can hear you.
Here you go. Hi, everybody. My name is Catherine Taylor, and I'm an engineer risk assessor for the existing chemical risk assessment division. And today I'll be presenting some topics from the occupational exposure assessment for 1,3-butadiene. Next slide, please. So this presentation will focus on charge question 4, which is relevant to the environmental release and occupational exposure assessment technical support document highlighted in yellow here in the 1,3-butadiene risk evaluation document map. The 3 topics covered in the charge question include the use of monitoring data that contains a large amount of non-detect samples, the use of analogous data from the same chemical but from other OESs when exposure profiles are expected to be similar, and our conclusion to not assess occupational dermal exposure due to the physical and chemical properties of 1,3-butadiene. Next slide, please. So the following slides are relevant to charge question 4AI, which addresses our use of monitoring data that contains a large number of non-detect samples. So within the 1,3-butadiene risk evaluation, monitoring data was used to estimate occupational exposure for all quantitatively assessed conditions of use, or COUs. This occupational monitoring data was obtained from multiple sources. The first source was the American Chemistry Council, or ACC's report titled Analysis of 1,3-butadiene Industrial Hygiene Data. And the report included a compilation and analysis of existing occupational air monitoring data, which consisted of over 5,000 full-shift personal breathing zone samples from both workers and occupational non-users, or ONUs, collected between 2010 and 2019. There's 47 consortium member facilities encompassed in the study, including both manufacturers and processors of 1,3-butadiene. The study also includes specific exposure data on a variety of similar exposure groups, which I may refer to as SEGs. EPA also obtained data from a comment submitted by the U.S. Tire Manufacturers Association, or USTMA, and from Lee et al.'s journal article, Work Environments and Exposure to Hazardous Substances in Korean Tire Manufacturing, obtained from Systematic Review. These 2 studies, which were used together in the assessment as they sampled from similar types of facilities, contained 102 full-shift personal breathing zone samples for workers from several facilities in 2020 and 2012, respectively. And then lastly, EPA obtained data from the Occupational Safety and Health Administration's Chemical Exposure Health Data. This included, also known as OSHA CEHD. This included 43 full-shift personal breathing zone, or PBZ, samples from workers at 5 facilities. And these data were collected between 2000 and 2016. Next slide, please. So non-detects occur when a sample is below the limit of detection, or LOD. The limit of detection is the lowest concentration of a chemical that can be reliably detected, and the LOD will differ depending on the sampling method and the air volume, and so different samples will have different LODs. In the ACC dataset, 86.8% of the full shift samples were below the limit of detection. The limit of detection ranged from 0.0008 ppm to 1.3 ppm. Since ACC had different data sets for different SEGs, the amount of non-detects varied from different data for the different data sets. Only one full shift SEG consisted of 100% non-detect samples. The remaining data sets did contain at least one quantified data point above the limit of detection. In the USTMA and Lee et al. Data sets, 64.6% of the full shift samples were below the limit of detection, which ranged from 0.008 ppm to 0.95 ppm. And then in the OSHA CEHD data, 100% of the data was below the limit of detection of 0.09 ppm. Next slide, please. So to conduct a quantitative occupational exposure assessment, a substitution method was used where non-detect values were substituted with the sample's LOD divided by 2 or the square root of 2, and the choice of which of these 2 substitution methods was used depended on the geometric standard deviation for each of the relevant data sets. In the case of the data set with 100% non-detects, the LOD divided by 2 was assumed to be the median or central tendency of the exposure, and the LOD itself was assumed to be the conservative high-end exposure. The substitution method for handling LODs is consistent with EPA's guidelines for statistical analysis of occupational exposure data. Next slide, please. The following slides are relevant to charge question 4BI1, which addresses our use of analogous data to inform some exposures in the 1,3-butadiene occupational exposure assessment. And so in a chemical risk evaluation, COUs, conditions of use, are the circumstances under which a chemical substance is intended, known, or reasonably foreseen to be manufactured, processed, distributed in commerce, used, or disposed of. And a chemicals risk evaluation will be made up of multiple COUs. Occupational exposure scenarios, or OESs, are tools used to characterize a COU's release and exposure potential, and they allow for grouping of similar activities across COUs, or they also allow for a broad COU to be split if there are multiple segments of the COU that are best assessed with different methods. And so the image on the slide illustrates the different ways an OES and COU may map to each other. One COU may map to one OES. Many OESs may fall under one OES, or one COU may be split into many, well, shouldn't say many, several OESs. So for 1,3-butadiene, EPA mapped the 28 COUs to 15 OESs. Next slide, please. So the 1,3-butadiene risk evaluation used monitoring data to quantitatively assess each OES. One source of this monitoring data, as mentioned already in the presentation, is ACC's analysis of 1,3-butadiene industrial hygiene data. And so this data set includes inhalation data for a variety of different similar exposure groups, or SEGs. And these SEGs captured several descriptive tasks and included data points from routine, non-routine, and turnaround operations. And these data were rated high quality in our data quality rating for occupational exposure and systematic review. The monitoring data from the ACC report was used for 7 out of the 11 OESs that were assessed quantitatively in the assessment. And of those 7 OESs where the ACC report was used, 3 of the OESs used data that were directly applicable, meaning that the data available from ACC was for the exact OES that the assessment was estimating occupational exposure for. And in the other 4 cases, these cases being repackaging, laboratory use, waste handling, and recycling, data of specific tasks and job descriptions from the ACC dataset were used as analogous. And these are the only cases in the assessment where analogous data was used. Next slide, please. So analogous data are data used in an exposure assessment that are of the same chemical, but for a different yet similar OES. It can be used as our best estimate of worker exposure in cases when we don't have any chemical-specific data that is directly from a given OES. And so in these cases, although there was no directly applicable data found, EPA determined that some data from the ACC's analysis could be used as analogous due to similar expected tasks among the workers. So there's some considerations to take into account when using analogous data, including that the same tasks done at 2 different types of facilities may not align perfectly. The tasks performed and what a worker is exposed to working in a laboratory setting at a manufacturing site, for example, may vary compared to a worker doing a similar task, but at a commercial lab. There's also some conservative assumptions that were made when using the analogous data. Task-based data may be used to extrapolate to full shift exposures when full shift monitoring data was not available. An example of this, or for example, it may be assumed that a single task, such as loading and unloading, may happen, it may happen once at a manufacturing site, but it could occur throughout the day at a repackaging site or at a repackaging site as opposed to a manufacturing site. And so, yeah, there are a few alternative methods for using analogous data, including use of surrogate data, which is data from the same OES, but from a different chemical, and then modeling. So in the absence of directly applicable personal breathing zone data for those four named OESs, given the similarities between the specific tasks performed and the similar expected exposure sources, use of analogous data for estimating occupational exposure was deemed to be the best available science. Next slide, please. Okay, so this slide is relevant to charge question 4BI2, which addresses our decision to conduct a qualitative assessment for occupational dermal exposure. The overall goal of an occupational exposure assessment is to estimate the exposure that a worker or occupational non-user or ONU may encounter. And in general, our assessment assumes that the occupational exposure may occur via either inhalation or dermal routes. For 1,3-butadiene, though, dermal exposure was qualitatively assessed, and a qualitative assessment for dermal exposure was supported due to the following. 1,3-butadiene is a volatile chemical and it is a gas at room temperature. During transport, 1,3-butadiene is condensed under high pressure into a liquefied form. And if a leak should occur, rapid evaporation of that liquid from a pressurized system would cause frostbite if it gets contact with the skin. And so due to the severe hazard, robust personal protective equipment is typically required when such an exposure is possible. And so dermal exposure is not expected to regularly occur. So this determination is consistent with EPA's Chemical Engineering Branch Manual for the Preparation of Engineering Assessments, which advises to assess dermal exposure to gas qualitatively and to expect negligible contact in situations where a chemical presents a hazard that would result in the high likelihood of PPE use, such as high temperatures or corrosivity. And so these principles were applied to the 1,3-butadiene occupational assessment. So in conclusion, due to the physical and chemical properties of 1,3-butadiene, EPA conducted a qualitative assessment of occupational dermal exposure. Next slide, please. Yeah, thank you for your attention, and we appreciate any input you may have.
All right, thank you very much. Let's see, do we have questions from the committee? Mr. Wright.
Yes, first, thanks for a terrific presentation. A lot of information well presented. I want to ask first about the ACC data sets. I'm trying to figure out what exactly they are and where they came from. And my suspicion is that they came from the OSHA standard, which is to say the standard requires certain operations, ones that have been over the PEL of one ppm, to conduct periodic sampling. And is that what the ACC's data set consists of, or is it something else?
So are we muted? Are we muted? Yeah, could you just give me a sec to confer, please?
Sure.
While we're waiting, Dr. Mayer and Dr. Johnson, I've got you in the queue, so we'll be ready for you when Ms. Taylor or one of her colleagues return from EPA.
George, I got one other as well.
Well, yeah, go ahead and ask all of yours.
Okay.
Hi, would you prefer to, yeah, I guess I can address this one. Yeah, so So yeah, as the presentation said, that the AC data, the ACC data is a collection of many kind of full shift and task-based samples. And so it wasn't, well, I guess the safety plan that, or like the report that they submitted is in the docket, and the reasons why they collected the samples are in that report.
Okay, thanks. One other brief one. I'm trying to figure out how some workers might be classified. When a tank truck comes into a facility, sometimes the driver gets out and he or she is the one who, attaches the hoses and handles the unloading. In other circumstances, somebody comes out from the plant and handles the unloading. How would those two workers be treated the same in the data set, or would the one who was the truck driver be considered a transport worker? And if I remember correctly, the analysis did not include transport. So how does that work exactly? It's the same job. It's just done by in some cases the driver or somebody who accompanies the driver, and in other cases it's done by personnel from inside the plant.
Yeah, I would want to look actually at the report to see exactly what's written about that. But I do know that these cases of loading and unloading are like there are several cases of loading and unloading workers that are like included, but they're task-based samples. Who exactly those workers are is something I would have to refer back to the ACC report about. But there were workers that would have been covered under that. But yeah, who exactly, whether it was the truck driver or the employee on the site, I'm not quite sure.
Yeah, I guess specifically, would the truck drivers be included, or would they be excluded because they don't work for ACC companies and
Okay.
engaged in what might be defined as in what is obviously defined as transport, as opposed to processing?
Yeah. Can you give me a sec?
Sure.
You're still on mute. You're still on mute. Ms. Taylor,
Ms.
you're still on
Taylor,
mute.
you're on mute. You're on mute, Ms. Taylor.
Oh, can you hear me?
We can hear you.
Yeah, sorry about that. Yeah, we're gonna get back to you on that. Yeah, we just want to confer the source again to double check on that. But yeah, thank you very much for the question. It's a good point.
Thank you.
So yeah, thank you for the discussion. We will want that response by the time we get to that particular charge question later in the week. So thank you for that question and comment. Dr. Mayer.
Yeah, thanks so much. And these are just quick methodology clarification questions. I know we'll be discussing some of these in the charge questions, but I just want to make sure in preparation for that with regard to the less than LOD samples, I wanted to verify that, it's clear what was done. The substitution method that was done is clearly described. I just wanted to verify other methods weren't also done. I didn't want to make sure I'm not missing a sensitivity analysis or other information.
Yeah, this is Catherine Taylor with the EPA, and that's correct. We don't use any other methods for handling data below the limit of detection.
Thank you. And another quick one is with regard to the dermal assessment, I wanted to just verify that there was no evaluation of vapor phase exposure to the skin.
Yeah, this is once again Catherine Taylor of the EPA, and that is correct. We do appreciate your feedback on the issue, though.
Great, thank you. Another, I think, hopefully quick one. George raises, Dr. Cobb raised this earlier. Wanted to verify for the occupational exposure summary tables that EPA is calculating the 95th percentile of the data and not the 95th percent upper confidence limit of the mean. And
Yeah, this is Catherine Taylor of the EPA. Yeah, I can confirm that it's of the data, 95th percentile of the data.
okay, and only one more. I just wanted to check and verify. I thought I read that for samples that were below the full shift samples, where the sample duration was not the full shift, well, was that concentration assumed to be the full shift equivalent, or was, I thought I read somewhere that zero exposure for the unsampled period was assumed?
Yeah, if you'll just give me a second.
And that question does not apply to the task sample situation.
This is Catherine Taylor of the EPA, and yes, that is the case. In those cases of analogous data being used where there was task-based sampling, particularly in repackaging and waste handling and recycling.
Okay,
Yeah,
we can follow up later, but my question was for the not those, all the other ones. So if the sample was 440 minutes instead of 480 minutes, and the concentration was 10, that wouldn't be that high, but just using the number 10, would you assume 10 for the 480 minutes, or would you assume 10 for the 440 and 0 for the rest? I just want to make sure that
okay, yeah, yes, we would.
Which one?
Oh, sorry, the 0 for the rest. Yeah.
Okay. That's what I thought I read. I just wanted to verify. Thank you.
Yeah.
And that's a great question, because that came up in one of our more recent reviews of a separate chemical. So great question. Thank you for the answers. Dr. Johnson.
Yeah, hi. I was curious, are there any situations, any OESs where you use analogous data from OESs to where you did have data? I want to make sure I read that properly.
Yeah, you can unmute. Hi, this is Catherine Taylor at the EPA. I'm going to double check the risk evaluation to and just double check just our sources to see if there was cases where we chose to use analogous data instead of data from other sources that maybe were more relevant, like maybe the applicability was better, but for other reasons in those cases there was likely other situations with the data that would have made us prefer to use the analogous data that we did choose to use. But I do want to double check on if we have exact situations where that happened. So
okay, yeah, check the laboratory technician OES, if you would, for me. And
okay.
One other question, I don't know if it fits here or not, but did you just do a mathematical evaluation to see for any OESs, if you had nothing but non-detects, would you still result, given the methods that you use to evaluate non-detects, could you still result in unacceptable cancer risk?
This is Catherine Taylor of the EPA, and that's possibly yes, depending on the LOD of the data.
Okay, thanks.
And Dr. Samuel.
Thank you very much. This is Dr. Jennifer Samuel of the SAC. And I just had this is a little bit related to what Dr. Johnson just asked, which I just wanted to clarify the number of the OESs and where the data came from, just to make sure that I have that right. So I think you said there's 15 total OESs. Of those, 7 of 11 OESs used data directly from the ACC, which sounded like it took those data from their SEGs that were determined by the ACC data or what was reported from the ACC. And then there was 4 of those that used analogous data. And then there were 3 others that had their own separate specific data set, but I think that's only 14 OESs. So I just wanted to see if I'm still missing one or what was used for the other one. So I think it's 11 plus 3 if 7 of the 11 used analogous data. Am I understanding that right? I just wanted to clarify. Thank you very much.
This is Catherine Taylor of the EPA. I'm just going to take a sec to double check on that for you, so I don't have to do it on the fly.
Thank you so much, and thank you for the very nice presentation as well.
And then Mr. Wright.
Yeah, this is just a simple definitional one. I'm curious about what exactly repackaging is. Is it, for example, if you get excuse me, if you get 1,3-butadiene into a facility and it's somehow put into a different kind of package or a different reactor vessel, let's say, is that what repackaging is? Or if you make the 1,3-butadiene into a product like ABS, and then package the ABS, would that be considered repackaging?
This is Catherine Taylor of the EPA. Yeah, it would be the former.
Only the former.
Butadiene being, yeah, repackaged. That's right.
Okay, thank you.
And just for clarity, you know, Ms. Taylor, you said that you were going to take a second to look up something, and I assumed that meant you were going to get back to us later and not right away. But if I cut you off by giving another question, I apologize. But just for clarity.
Yeah, that is my assumption.
Okay.
Yeah, that I just want to take a second, make sure I get the right answer.
And I'm going to take one chair privilege just to get something on the record before I forget that by the time we get to it. In this case, I think that assuming that PPE will be worn in a lot of these cases is correct, but the SAC has been very clear with the agency that the risk assessments need to be done in the absence of PPE and then refined to include PPE if it is justifiable or justified. So, and that's probably, I shouldn't have said that here, but I might forget it before we get to the end of the week. Okay, I think that brings us to very nearly break time, so perhaps we should do that. I'll turn this back over to our DFO to make sure we're all on the right task. Before I do that, I want to mention to all of the committee members and to the EPA staff, we're going to circle back and see if there are questions about anything that we've done today right after this break. So that's going to be the first thing we do. I'll take roll, then we'll circle back, see if there are any additional clarifying questions from earlier today, and then we will move into our last portion of the afternoon.
Yes, thank you, Dr. Cobb. So yeah, we're it's 3:08. We can go ahead and take our 15-minute break now. So if you could please have the timer on, that would be great. Thanks.
Thank you.
Okay, see you back in 15. Everybody put yourself on mute and turn off your
Okay, I think we can get started back. This is George Cobb, the chair of the EPA Science Advisory Committee. Hoping we can get ourselves started back now. And let me take the roll really quickly so we can make sure we've got enough members here. So I'm here, Dr. Apti.
Yeah, I'm here.
Dr. Chason.
I'm here.
Dr. Ike, did you make it back? Probably not. Dr. Fox?
Here.
Dr. Gentry?
Here.
Dr. Heiger Bernays?
Here. Excuse me, here.
Ms. Jenkins?
Here.
Dr. Mercedes Nieves, I see you there.
Here.
Dr. Rubin?
Here.
Dr. Samuel?
I'm here. Sorry.
Not worry. Mr. Wright?
And I'm here.
Okay. And Dr. Santos?
I'm here.
George, are you frozen? Dr. Cobb, are you frozen?
I think he is.
Okay. Well, I can go ahead and take over the roll call while, so let's see, so we started with, let's see, Dr. Santos, and
Here.
I saw him, he had his hand raised. Yes, he's here. Catherine Roby.
I'm here.
Mark Johnson.
I'm here.
Okay. Lisa McKenzie. All right, we'll move on to Ann Fairbrother.
I'm here.
David Eastman.
I'm here.
Lauren Hopkins.
Here.
Laura Bean Friedman.
I'm here.
Penelope Fenner Crisp.
Here.
And Andrew Mayer.
Yes, I'm here.
All right, so the next portion of our agenda is the public comments. And so the oral public comments. And so we will go ahead and get started with an oral public comment by Chris Kerman at Cy Pinion, who is representing ACC on a 45-minute oral comment. So if Mr. Kerman.
I'm sorry.
Yes, yes.
I'm sorry,
yes,
Allie.
Dr.
We've skipped a portion of the agenda. There's one more technical presentation listed after the break.
I'm sorry. Thank you for pointing that out. We have one more presentation, and it is by Mr. Kit Lee. He will be going over the draft 1,3-butadiene risk evaluation organization and transparency.
Thanks, Allie. Good afternoon, everyone. This is Kit Lee again with EPA. I will be briefly presenting charge question number 6, which is related to risk characterization principles. As shown in the presentations throughout the day, EPA's risk evaluations are made up of technical support documents accompanied by a summary risk characterization and risk determination. It is important that the information presented in these documents is clear and concise and describes the risk evaluation process in a scientifically credible manner. The EPA's Risk Characterization Handbook cites transparency, clarity, consistency, and reasonableness, or TCCR, as critical principles for risk characterization. To this end, EPA is utilizing the draft risk evaluation along with multiple technical support documents to present information in a manner most appropriate for each component of the risk evaluation. Transparency refers to the explicitness in the risk assessment process, It ensures that any reader understands all the steps, logic, key assumptions, limitations, and decisions in the risk assessment, and comprehends the supporting rationale for the weight of evidence and conclusions. Clarity ensures that the documents are clear, free, and are easy to understand by all readers. Consistency refers to the approach and conclusions of the risk assessment, aligning with relevant policy, guidance, and rationales of other assessments, and provides reasoning and support for any alternative approaches and conclusions. Reasonableness refers to the context of the current state of the science, the assumptions, and the policy choices made, and demonstrates that the risk assessment process followed an acceptable, logical path that is based on sound judgment. For the final charge question, EPA requests feedback and comment on the overall organization and presentation of the draft risk evaluation and its technical support documents, and for improving the transparency, clarity, consistency, reasonableness, and importantly, the usefulness of the technical information for intended users, which include internal and external partners and stakeholders, other EPA offices and other agencies and regulatory bodies, as well as the public. Next slide, please. And with that, that concludes the Office of Pollution Prevention and Toxics technical presentations for today. I'd like to thank Ali Munir for help preparing and setting up the meeting, the SAC meeting, and thank Dr. George Cobb for moderating. I'd also like to thank the 1-3 Betadine team and the senior science advisors for all the hard work and collaborative effort that was put into the draft risk evaluation and the presentations. Lastly, I'd like to thank the ad hoc reviewers and the members of the SAC panel for your attendance and for your key role and contributions throughout the TSCA risk evaluation process. Thank you.
Thank you, Dr. Lee. So I will open up the floor to the committee if they have any questions for Mr. Lee. Yes, Dr. Santos Burgoa.
My apologies for being jumping at every question, but
no problem. That's what we're here for. That's what this is for.
No, but thank you very much. Just a quick comment. This is my first time I participate in something like this, and it's amazing the amount of information that you organize, and you organize in such a way that you have these core documents and then the supporting documents. So I would like just a clarification of what do you expect from charge question 6? What do you expect to get? If I say it's complicated for me to go through all these documents, is that enough? Or what do you expect from us to learn from how can we better contribute to charge question 6? I'm not responding directly to that one, but I would like to contribute.
I'm sorry, in the interest of Dr. Cobb, I still think not being here, can you clarify, are you asking your fellow SAC members and the chair how you can contribute, or are you asking EPA how best we can be supported with a response?
No, I want to ask EPA, what do you expect to gain from our input?
Understood. Okay. So I think what would help us in that charge question is understanding how the information can best be presented in future risk evaluations or in the draft to final revisions that we make for this risk evaluation to best the readers, you yourselves as SAC members and other stakeholders who may be using the risk evaluations in the future. I think, a bigger picture of how the risk evaluation is organized, if it could be done in a different way, that would be more, logical in terms of fitting pieces together. Those kinds of things would be helpful. I'll also call on any colleagues in the EC-RAD group who might have additional comments that they can provide in terms of what would be helpful.
Hi, this is Karen from the EPA. And just to add to what Kathy is saying, I think it is really about that organization, what makes it, what setup it makes it best for the reviewers to review, because our intent of the TSDs is to provide a product that not everybody has to read from page 1 to page 1,000 in order to get the context of the piece that they are primarily out there interested in reviewing, or just the public being interested in reading. The idea is to have a standalone risk evaluation without getting into every detail of the analysis. That's our hope with the TSDs, but we wanted feedback from you all, the users, to see how it is working for you and if there's any suggestions on how all of our work, because it is very detailed. There are a ton of analyses and they're very long documents, how it is best received by reviewers and the public. Hopefully that's helpful.
Thank you very much for the clarification.
And I'm finally made it back. This is George Cobb. Sorry for that, folks. And Ms. Munir is there, so I'm going to let you speak.
Okay, I'll finish this part out before you introduce the public comment section. So I'm glad you're back, Dr. Cobb. So I'm wondering if there are any other follow-up questions for Mr. Lee or for Dr. Eisenreich or Dr. D'Annunzio in regards to charge question number 6. All right, not seeing any hands raised, so I will turn it back over to Dr. Cobb for him to kick off the public comment portion of this meeting.
Okay, great. Thank you, Ms. Munir. And we've got lots of public commenters. We had up to 16. I think maybe some have decided not to participate. And full disclosure, everything I had open on my desktop is gone. So I do not have the list of speakers. So Ms. Munir or Mr. Ali, if you've got that list to get us started, that's great. Otherwise, I'm going to have to pull it up off of my files.
Sure, no problem. While you're doing that, I'll go ahead and get started on the public comment portion. So we'll go ahead and start off with Chris Kermans from Cypinion. He's representing ACC, and he will be doing a 45-minute oral comment talking about the human health hazard of 1,3-butadiene. I will now turn it over to Mr. Kerman.
Thank you, Ms. Munir, and thank you all for giving me the opportunity to speak to you this afternoon. Like Ms. Munir said, I'm going to be speaking on the topic of butadiene hazard. And full disclosure, I'm an independent scientist in toxicokinetics, toxicology, and risk assessment, but I am speaking on behalf of ACC's Butadiene Tosca Risk Assessment Consortium. Next slide, please. My talk's going to consist of essentially 3 components, a little bit of background information, followed by non-cancer assessment, and then comments on the cancer assessment. And just a little bit of a warning, we are going to get into the weeds a little bit on some of these slides that I'm going to touch upon, fairly briefly. For more information, please see our written comments, and I provide the link here, as well as our very recent risk assessment manuscript, which has also been submitted to the docket. Next slide. And just to acknowledge that this is just not me, my information. I'm also, want to thank folks that have been involved in this project. We've engaged an independent risk assessment science advisory panel member, and all the members are listed here. We've also engaged a separate panel on the topic of mode of action and dosimetry. And you can see the panel members listed there. For the non-cancer assessment and interpretation of biomarkers, Dr. Natalia Tretrikova from University of Michigan was very helpful. For the cancer assessment, I'd really like to acknowledge the entire University of Alabama team, including Drs. Sathya Kumar, who unfortunately is no longer with us, and Dr. Delzell, who has recently retired, as well as the sponsors for collecting all of the excellent epidemiology data for the styrene butadiene workers there. And lastly, my colleague, Dr. Siraco Valdez-Flores, for conducting some of the analyses that you will see in these slides. Next slide. A little bit of, taking a step back and looking at the big picture. Exposures to butadiene in the U.S. have been decreasing, and we can say this with high degree of certainty based on emissions data from EPA's data source, which you see in the upper left, to ambient air monitoring that we see in the middle panel, and then also for monitoring worker exposures. Those are all decreasing over time. If we look at how smoking behaviors, both in terms of intensity and prevalence, have decreased as well over time, so exposures from that pathway are also decreasing. Next slide. The CDC has collected biomonitoring data on the U.S. population, and that's an excellent resource for us to rely upon. And it tells us two important things. First is that based on a detection frequency of over 99%, everyone in the U.S. is exposed to butadiene in some manner. The question is how. Clearly, these data show that smoking is an important source of exposure for this chemical. The question is, how important are some of the other pathways? Next slide. We have conducted our own independent risk assessment on butadiene exposures. To do so, like I mentioned, we engaged an independent science advisory panel to support the decisions that went into that assessment, so that it's not just me making those decisions. And I list again the panel members and their affiliations here. We've also incorporated probabilistic or Monte Carlo methods, as well as the use of respirators on exposure estimates, both with and without respirators, I should say. And we've applied these Monte Carlo methods to both the toxicity assessment and the exposure assessments. We covered 26 exposure scenarios, and we also looked at aggregate exposures to, essentially look at what if somebody who works at a facility also lives near that facility and is also a smoker. What does that mean to their overall exposure and potential risks? We've made prominent use of the available biomarker data for this chemical. It's a really data-rich chemical, and we wanted to make the most use of that as possible. And we've used these data to support both interspecies extrapolation. We've used it for intraspecies extrapolation in terms of characterizing variation in people, and as well as quantifying the potential exposures to butadiene from smoking. And our risk assessment, just at the bottom line, is we came away with 3 primary conclusions. Next slide. The first is that, looking at all 26 exposure scenarios, and I've shown the results of one Monte Carlo evaluation of one of those scenarios of 26 in these figures here. We looked at the endpoints for both cancer risk, for non-cancer effects, for chronic exposures from ovarian atrophy, as well as subchronic exposures and producing fetal body weight changes. For all 3 endpoints and for all 26 scenarios we evaluated, we do not see an unusual risk of developing effects in people. Next slide. Conclusion 2 is that the existing occupational exposure limit of 1 ppm for butadiene is protected for all 3 endpoints. And you see basically Monte Carlo results and distributions for occupational exposure values calculated using EPA's equations And we see that the distributions all push to the right of the 1 ppm value that you see as that vertical line there. Next slide. And lastly, when it comes to different exposure pathways, we certainly agree that, based on its chemical physical properties, the inhalation pathway deserves focus for this chemical. We evaluated, in addition to ambient air, indoor air, in-vehicle air, as well as workplace air. And I just would like to point out that for in-vehicle air, the exposures and butadiene that you see in in-vehicle air is really driven by fuel combustion rather than off-gassing. And there's a study that I could cite specifically that evaluated the contribution from traffic, essentially, both exhaust from other vehicles as well as your own vehicle. For indoor air, we've also relied upon measured data for that. And there, in general, indoor air is going to be more important or have higher concentrations of butadiene than ambient air because indoor air has additional sources. These can be sources of combustion. If you have a smoker in the house, if you are burning wood or any other sort of source of carbon, you're likely generating indoor air sources of butadiene. So, and lastly, if there is a potential off-gassing of butadiene from products, it's going to be captured in these direct measurements of indoor air. Next slide. Oh, wait, I'm sorry, please go back to the previous slide. With respect to pathway contribution, these are the aggregate exposures. So the first upper left is essentially the non-cancer general population. And you can see in that one, the indoor air is driving their overall exposure, followed by in-vehicle air, and lastly, at 7.5% is the ambient air pathway. When we add smoking to that in the lower left, we see that then predominates the overall exposure, as indicated in the purple there. If we were to add a worker exposure to that, then that's in the upper right panel. That then dominates over the other exposure pathways. And then if you have all of those exposure pathways combined, then you can see what that looks like in the lower left. The take-home message here is the ambient pathway is a minor pathway of exposure in the US population. Next slide. In addition to being a minor pathway, industrial processes and sources of emissions to butadiene are a minor contributor to that minor pathway. So if exposures to the ambient air is contributing 70.5% or less to total exposures, industry contributions to that pathway are very, very small. And this pathway, this pie chart from EPA's database shows that that's about 2.2%. And the bottom line is that, the purpose of providing this is that, if the focus, any focus on industrial emissions of butadiene for the purposes of protecting public health might be misplaced from a top-down perspective. If you want to reduce exposures to butadiene in the US, then you really should focus on ensuring that the trends that we see for smoking in the US continue to decrease in the future. If, on the other hand, you want to manage the ambient air pathway, then as this figure indicates, that clearly the focus should be emphasized on wildfires and its emissions of butadiene to the air. It is the one source where the temporal trend is going in the wrong direction. Next slide. Moving on to the non-cancer assessment, these are two papers that we recently published on this topic, and we'll be presenting some figures from those slides, from those papers. Next slide. We agree with EPA's decision to rely on the fetal body weight changes in mice as the critical non-cancer endpoint. This has been used in the past by multiple agencies to derive non-cancer toxicity values, both in EPA's previous assessment as well as by other agencies as well. For butadiene, as well characterized by EPA, metabolism is a key determinant of both its toxicity and its carcinogenicity, primarily to the formation of 3 reactive epoxide metabolites. We'll talk about a little bit that on the next slide where I show a metabolism figure. And I just want to say, part of our product, part of our problem formulation step was consideration of ATSCR's recent 2012, not so recent, 2012 assessment, where they basically decided, given all the information we have for butadiene, they did not derive any minimal risk levels, which is ATSCR's equivalent of a reference concentration for any endpoints. And that's because the weight of evidence on the species differences for metabolic activation for this chemical is so strong and so prominent that they knew that if they just went down the normal path and calculated the way they usually do, they were going to overestimate risk to human population. So they decided, to their credit, not to go down that road. And so that was part of our problem formulation, that we need to rectify that decision, because there's too much data to use for this chemical to not derive a value. Next slide. Just to review butadiene's metabolism, it's the parent chemical at the top there has two double bonds that are subject to metabolism and oxidation by P450s. The initial oxidation to the monoepoxide, or EB, which is also then further oxidized to form the diapoxide, or DEB, that has is a bifunctional alkylating agent. And then that can undergo hydrolysis by epoxide hydrolase, such that one of the epoxides remains and the other has been hydrolyzed. Those are the three metabolites that have been the focus of the toxicity, mutagenicity, and carcinogenicity of this particular chemical. All three of those epoxide metabolites are able to form hemoglobin adducts that are specific to those metabolites. And we're going to spend some more time on that in a subsequent slide here. Next slide. With respect to the mode of action for fetal body weight changes, the data are limited, but there are some data to work with. And we did summarize this information. If you look in the key study, you see fetal body weight changes in mice, but the same study at the same lab found no effects in rats, which is consistent with what we understand about the toxicokinetics and the metabolic activation of this chemical by those two species. Within the key study, we see a very strong correlation between the fetal body weight changes in the fetus versus maternal body weight gain during the last part of the study. In non-pregnant animals, we can see that the diapoxide plays an important role in reducing, in general, toxicity and producing body weight changes. We see that in the non-responsive species administered the diapoxide, they are responsive to the diapoxide, and therefore we see body weight changes and reductions of body weight and other signs of general toxicity in that species that you don't see when you give butadiene alone. There is some uncertainty here. The role of other metabolites, particularly the EBD, or the epoxy butanediol, and that role in contributing to this endpoint is not sure. We have a different understanding on the ovarian atrophy side, where clearly all of those effects are due to the diapoxide, and can rule out anything that is not a diapoxide in format based on the excellent studies of Dorr et al. 1995, 1996. But the reason why EBD is important, I'll show this in a few slides here, is that it is the primary metabolite that we see in humans circulating in their blood following exposure. Next slide. I'm going to spend a little time on this slide. There's a lot of data to unpack here. After reading his 2022 paper, I reached out to Dr. Gunnar Boyson at the University of Arkansas to get access to his raw data to support our ongoing risk assessment. And that's what you see here. And for a toxicokineticist and risk assessor, these data are a gold mine. We can readily estimate internal doses of the butadiene metabolites in humans based on these data. All we need to plug in is essentially the reaction rates for adduct formation, which we have measurements, as well as the half-lives for erythrocytes, which again, we have measurements. So those are known factors. And so it's relatively simple to take adduct data and then estimate the internal circulating levels of metabolites in blood. And so what you see in this figure here on the x-axis is the log transformed exposure, external exposures to butadiene in workplace air. And these are essentially randomized collected personal air samples over a 60-day period in the workplace. On the y-axis, then we have a log transformation of the 3 specific adducts in individual workers. We have data for over 100 workers collected across 2 studies. There's really strong data. At the diamonds that you see at the top reflect the epoxybutane diol adduct, and that's the most prominent that we see in humans. The stars that you see there reflect the monoepoxide, or BEB, the adduct from that. And then the triangles are the lowest, and that reflects the diapoxide and the adduct that it forms. Now, in the early 2000s, when EPA did their last assessment, essentially all of the worker data for the diapoxide were non-detects because the analytical methods simply weren't good enough to find them. The levels were much lower than what we were seeing in the animals, and we just didn't have the sufficient detection limits to do that. Thanks to Dr. Boyson and others at Jim Swenberg's lab, those analytical methods were refined and such that we now have actual measurements for the diapoxide adduct that you see here in the diamonds at the lowest portion of this graph. We also have companion data for adduct formation in mice for all 3 metabolites. We also have it in rats for all 3 metabolites. So it's really strong data, and it's excellent data for estimating and quantifying the species differences in the internal dose of metabolites as a function of external exposure. In addition, these data are super valuable for characterizing inter-individual variation. You can look at the residuals for each of the 3 metabolites, and we have done so to support our assessment. First, we've used these data to support data-derived extrapolation factors for interspecies extrapolation. We have also used these data to characterize and calculate data-derived extrapolation factors for individual variation. And you can see that the variation in the main metabolite, the EBD, is fairly modest. And it is also fairly modest for the monoepoxide that you see in the middle. But the diapoxide variation is actually larger than the default factor of 3 that you normally apply for human toxicokinetics. It's more in the lines of maybe 6 to 8. And that's an important factor that we considered in our assessment when we defined what was an appropriate margin of exposure. So yes, we did quantify the species differences in the metabolic activation, but we also recognize that there's greater variation for some of the metabolites. When we consider all 3 metabolites combined, then a factor of 3 seems about right in terms of characterizing the variation. Now, these data, you should view any internal dose estimates from these data with the same weight as if you had a PPK model for butadiene with the highest confidence. And last thing I'd like to point out is that when I reached out to Dr. Boyson, I was really only aware of data for male workers, which you see in the blue here. He asked me at the time, would you like to have the data for female workers? And I was surprised because I didn't realize that existed. And I said absolutely, because we had identified that as a data gap in our 2022 paper on non-cancer risks. And so he was kind enough to provide that to me. I expressed to him the importance of these data in the risk assessment. And you see those in red here, both in terms of the diapoxide red triangles and the EBD, the primary metabolite, in the diamonds at the top there. I indicated the importance of these data for the risk assessment and characterizing risks, and encouraged him to publish these data on their own so that I'm not the only source of them. They're kind of buried in the appendix to a risk assessment that we did, but they really deserve more prominence than that. So I've encouraged him to publish that. He has done so. It has been submitted, and I believe he's addressed comments. So it just went back to Chemical Research and Toxicology. That should be appearing in print really soon. The raw data that you see in this figure are actually going to be part of the supplemental material and available to anyone if you need it sooner. You can do the same thing I did, just reach out to Dr. Boyson at the University of Arkansas, and he'd be happy to provide it to EPA or to the SAC or anybody who is interested. Bottom line, these are really strong, high confidence data. And if you need a precedent in using these data, please look at EPA's IRIS assessment for acrylamide. They essentially used hemoglobin adducts in that assessment for both rats and humans to quantify species differences in the internal dose for that particular chemical. Next slide. Here's how we use the data to support data-derived extrapolation factors. And what we've done, at least for the fetal body weight endpoint, is we're considering the contributions from all three metabolites. So we've essentially adopted a relative potency approach to do this. And so what you see here is what we're calling a cytotoxicity index, which is essentially a product of the internal dose estimates that we have based on the hemoglobin adduct data that I just showed you previously, versus as the product times its relative toxicity. In every assay that we've ever looked at, in vitro, in vivo, the diapoxide is always the most potent of the metabolites that we've looked at. We're fortunate to have 6 studies that look at the relative toxicity potency of all 3 metabolites within the same test system. So it's really an excellent data set to work with. The surface area that you see in these pie charts essentially indicates the magnitude of the differences across species. So you can see that the internal dose of cytotoxicity equivalents in mice is much, much larger than you see in humans. And the rats are somewhat intermediate of that. More importantly, the composition, what's contributing to the toxicity, is very different between rodents and humans. In mice and rats, the diapoxide is almost exclusively the driver of the toxicity. In humans, that's not the case. It's the EBD, or the epoxybutanediol, that is contributing almost the majority, almost all of the toxicity based on, and that corresponds to the highest hemoglobin adduct that you saw in that previous slide there. The diapoxide is contributing relatively modest, less than 5%. And for all 3 species, it was interesting to find out that the monoepoxide is essentially negligible and could be ignored from the quantitative assessment. If we chose to do that, we did include it, but it's not an important contributor in any species. And the story we have here with butadiene is essentially that the past practices as a matter of policy in terms of selecting an appropriate test species and relying on the most sensitive, and then assuming humans are then equally or more sensitive than that species, has kind of landed us in the wrong ballpark. And not just by a little bit, but by a factor of 100 to 1,000. And it's something that we need to fix. We have better data that we can actually do something and work with. Next slide. In applying the data-derived extrapolation factors, we can actually improve the dose-response concordance that we see in the test data that we have. What you see on the left-hand side panel is the dose response for fetal body weight changes in mice with the dashed lines versus rats, the non-responsive species, in the solid line. Unadjusted, you can see 2 different pictures as to what's going on with for fetal body weight. When we consider the differences in the dose and the toxicity of the metabolites, you see that the reason the rats are non-responsive is because their internal doses are much, much lower for the toxic metabolites, and such that their data is all pushed to the left, and therefore we're getting improved concordance. We can explain why the rat is not responsive to that particular endpoint and in that study. We do recognize, however, there's uncertainty and variation in these data-derived extrapolation factor calculations. So next slide, please. And so what we've done, and this is another appendix to that risk assessment paper that I had a link to on the first page, is that we actually did a Monte Carlo evaluation of those data-derived extrapolation factor calculations we essentially performed two different calculations. Essentially, what if toxicity is attributed to the diapoxide alone, which is hypothesis one? What if toxicity is attributed to the combined contributions from all three epoxide metabolites? We used the variation in the internal dose estimates as quantified by Motwani and Tornquist in their 2014 paper. And I highly recommend that paper be read. I think the species differences that they quantify in there are particularly robust, that we've incorporated in our assessment here. And the most interesting thing about that paper is they actually validated those species differences by a completely independent manner using in vitro studies and IVE scale up. They get essentially the same answer from a completely different data set as you do with the hemoglobin addicts. And that's one of the reasons why we have such high confidence in them. And so in our Monte Carlo evaluation, we essentially looked at the uncertainty and variation in those. We also looked at the hypothesis 2 and the contributions of all three metabolites. We looked at the variation in the relative potencies across those 6 studies, and we basically came out with results that for hypothesis 1 attributing to just the diapoxide, that the distribution is very, very tight. Well below a factor of 2 will cover that particular uncertainty and variation. For hypothesis 2, where we're looking at all 3 metabolites, it's a little bit larger, but it's still about a factor of 3 that we're looking at, deviating from central tendency or best available or best supported value. So again, these are manageable numbers in terms of dealing with uncertainty and variation in these types of data, and we don't find anything in these calculations that would deviate or preclude from their application in the quantitative risk assessment. So I have the 2 values here. For the fetal body weight endpoint, we focused our assessment primarily on hypothesis 2, that all 3 are contributing, because we feel that the EBD metabolite, which is the prominent one in humans, we can't dismiss it. We do not have the data to support that not playing a role in that endpoint, so we had to include it. But we do think that there is a strong likelihood that any endpoint that you see in a mouse, but not a rat, that it's the diapoxide that's really driving things. And so that second data-derived extrapolation factor deserves some place in the discussion of uncertainty. Next slide. Recognize there's uncertainty in this, and so we wanted to run this by a separate panel of independent experts, again using a triple blinded process where the panelists didn't know who the sponsor was. The sponsor played no role and didn't know who the panelists were until the very end. And the panelists actually didn't know who each other were. They were just known to each other as experts 1, 2, and 3, and 4 throughout the online deliberations. So we're trying to take away as many sources of bias in the process. We did use a modified Delphi process in this panel, as well as our science advisory panel for the risk assessment, so that we can collect both their independent input on the charge questions, as well as their deliberative endpoint input, which is as you are doing right now. Next slide. Here is a list of the science, the mode of action panel and dosimetry panel experts that we engaged. There should be some names on there that you recognize. These are very senior risk assessors, many former agency folks. And I will point out that we actually include 2 of the authors of EPA's guidelines for deriving data-derived extrapolation factors. Next slide. And what we found for the fetal body weight endpoint, we actually had them consider both ovarian atrophy and the fetal body weight endpoint modes of action and dosimetry decisions. For the fetal body weight endpoint that I'm presenting here, the panel's overall conclusion was medium confidence in the mode of action. There is some uncertainty, particularly for the late key events. However, when it comes to dosimetry decisions, majority of the panel supported essentially hypothesis 2 that I presented before, where all 3 metabolites are contributing to toxicity. One panelist recommended doing it both ways under both hypotheses and relying on the more conservative of the 2, which is what we did in our risk assessment. And then one panelist just had a general recommendation for conservative. I think most importantly, none of the panelists recommended using unadjusted external concentration, which was the approach that EPA used in their draft assessment and was the approach that was specifically rejected by ATSDR in their 2012 assessment. Next slide. Now this is a summary table that just provides a take home of the magnitude of the differences and the impact of these data. We're talking again 2 to 3 orders of magnitude, depending on which hypothesis you move forward with. We're using the more conservative of those two because we recognize their uncertainty in the role for other metabolites other than the diapoxide contributing. I did include in this table, but did not discuss the point departure deflection, which is slightly below the range of observation for the key data set. And so you might consider bumping up the benchmark response rate a tad just so that you get closer to the range of observation. There is certainly precedent in EPA's IRIS program for using higher benchmark response rates, even for things such as fetal body weight within. So it wouldn't be the sole chemical that relies upon that. And so taking consideration that there's a dramatic change in what the point of departure should be to support the risk assessment, as well as a dramatic change in the proposed occupational exposure value that's calculated from that point of departure. Next slide. Moving on to the cancer assessment, here's a couple of studies, a couple of them I've been involved with, and as well as those that were the excellent study from the University of Alabama folks. Next slide. We believe that EPA has definitely landed on the right data set and the right endpoint to support their assessment. These data were considered to be of from this cohort, these data were considered to be of high quality back in 2002, and it's only improved with age. We've got more descendants with greater statistical power, more years of follow-up. We've got refined exposure estimates, and we now have female worker data. So it's all been, it's just gotten much, much better over the past 2 decades. And this data has been extensively published. The University of Alabama folks have published 17 papers. Myself and Cyriaco have published a handful of more. It has been extensively reviewed by health agencies across the world, and it has also been formally audited by the Health Effects Institute back in, I believe, 2004. However, we do believe that EPA should be relying on the full cohort data set rather than on a partial data set. And in selecting the trimmed analysis to support the Cox proportional hazard slope that was selected for the unit risk, 2 pieces of data were basically excluded from the quantitative evaluation. The first being that for non-exposed workers, and I think hopefully most folks would agree that we are characterizing and modeling basically rate ratios. And the denominator of that ratio, that's where the data for the unexposed workers is particularly valuable. So it's very important to the entire data set because we're looking at rate ratios. And I think that the logic for excluding the unexposed workers is flawed. If you were to take that and apply it to essentially animal data, then we wouldn't use the control animal in the dose response. That just doesn't make sense to me. So we would like EPA to reconsider that point. And then the second piece of data that EPA basically excluded from the assessment was the highest exposed workers. And I'll show here on the next slide that those are not outliers. So what we have here is essentially on the x-axis, we have cumulative exposure ppm years of butadiene to workers in the SBR cohort. On the y-axis, we have then the rate ratio for leukemia. And then rather than looking at quartiles or deciles, we basically stratified these data to the highest extent we could to depict this. So you can see the scatter. Essentially, we divided it so you have essentially 1 case of leukemia per group. And that's about as stratified as you can get without going to continuous data. And so what you see that those above the 95th percentile, those 6 data points, are not outliers. They are falling completely consistent with the rest of the data. And I think it's these are the data that are essentially helping drive the statistical significance of the leukemia response. And it's here in these at the very high end, we're seeing clear differentiation from a rate ratio of 1. So excluding these data really is not justified when it comes to characterizing the inhalation potency estimate. Next slide, please. When it comes to looking at statistical principles, I think one of the other reasons why you might exclude data is you're just not getting a good fit to the data by the model, but that's not the case here. With the entire data set, we actually have a better p-value for the full cohort data set than with excluding the data. So it's just not a statistical argument for making that exclusion. The steepness of the slope is not should not be driving which data set to rely upon. That's a slippery slope that can actually move towards excluding more and more of the data to get an answer that you want rather than one that's supported by all the data. And so that's not the approach that we recommend here. We believe that the full cohort is really the appropriate basis for any quantitative assessment. Next slide. With respect to adjustments to the data, I think we are in agreement that a zero lag is appropriate for both the leukemia endpoint and for the bladder cancer endpoint because it really isn't having an important influence on the results. With respect to response adjustments and consideration of covariates, there's no real guidance here on from the agency in terms of what should be included and what should be excluded. And really the decision on what gets included or excluded may depend on what type of modeling you're doing. There's explanatory modeling, and you want to try to understand the role of interventions and how each of these things may contribute. Versus predictive modeling, where you may want to focus on just the things that matter. There's no real guidelines on how that should be done. So we think that there is a justification for including the number of high-intensity tasks as a covariate. And the high-intensity task reflects a number of exposure events, a cumulative number over their occupational tenure. It is not the ppm years of exposure that they experience during those high-intensity tasks. So it's essentially a way of modifying the cumulative exposure of ppm years. Not all ppm years may be equal. Those that have more peaks seem to be more potent in terms of producing the leukemia response. Those that are lacking peaks, essentially your longer, more low-level exposures may be less important to driving the leukemia response. So we believe there's both a statistical and biological rationale for supporting the inclusion of peaks, but we recognize that there's uncertainty in this, and like I said, no guidelines. So it really falls to the SAC here as to what should be the driving factor for what covariates get included and what does not. And lastly, I think it was unfair that Dr. Ciriaco Flores and my paper in 2002 kind of got dinged because we included hits for the systematic review and the scoring. We kind of got dinged for including hits, but we feel that's kind of unfair because we calculated a number of different ways, including hits, excluding hits. There's so many numbers in that paper. I invite you to go look at it, but just the fact that we included hits of covariate should not be a rationale for downgrading the quality of that particular study. Next slide. We think that EPA's, we agree with EPA in selecting Cox proportional hazards as the appropriate method for estimating cancer potency from the SBR cohort data. However, we do believe that EPA has made an error in its description of the work of the University of Alabama. And while they did use the restricted cubic splines for some portions of their work, particularly the figure 1 that they show there, it was not used to generate the slopes. And I think this paper is somewhat ambiguous. And so I was misled when I first read it as well, and was corrected by other folks who know better, that this is actually the traditional Cox proportional hazards model that's being used to generate the slope values that EPA is selecting from. I think another point that you could consider when it comes to selecting the slope is looking at the history of the historical weight of evidence for this data set and for analyses of these data sets. And you'll see this in the next slide here, that it's been a well-studied cohort data, and the slope from the modeling has been relatively stable, resistant to updates over time, as well as resistant and stable to what covariates get included versus excluded. And so you consider the weight of evidence from historical analyses as another piece of in some selecting what's an appropriate slope value. So we essentially have two recommendations that either we should be looking at hits and including that based on both statistical and biological arguments, or two, consider the weight of evidence from the history of this data set and selecting something that is more consistent with what we see. And so, and that any deviations like the value that EPA has selected, that 0.000994, which kind of falls outside the historical range, that deserves some discussion in any discussions of uncertainty. Next slide. So here's that table. It's difficult to read, but essentially you have over the past 15 years, multiple analyses and updates of this cohort, and you can see the vast majority of the slopes are falling within a fairly tight range. So it has been very, very stable. There are some deviations. If you include hits, then the value of the slope will be lower, and the value that EPA has selected has really kind of is the one that really kind of exceeds the historical range. Next slide. Two aspects with respect to the point of departure. The first has to do with the confidence intervals that are selected, University of Alabama presented one confidence interval, a 95th% confidence interval, which goes up to essentially the upper bound is the 97.5th percentile, whereas EPA's historically relied upon a 90% confidence interval, which goes from the 5th to the 95th percentile. This does make a small difference in the actual value, and we think that the EPA should be not just relying on what University of Alabama reported, but should consider historical practices within the IRIS database. And then the second point is the benchmark response rate of 1%. While it's lower than the default for animal data, it's too high for this data set. And this decision comes down specifically, what's the range of observation defined by the data you're working with? And according to EPA's guidelines on benchmark dose, you need to select a point of departure that's coming from essentially the lower or left-hand end of your distribution, defined a range of observation defined by the data. And unfortunately, it looks like the 1% is actually falling from the upper end. And I'll have a figure to show that here in a slide or two. And the bottom line is that we think that a lower benchmark response rate of 0.01% or even lower, that's about 10 to the minus 5, all the way to 10 to the minus 6, would be appropriate for this particular data set. And we think that the 90% confidence interval, consistent with historical practice, is the one that they should be relying upon. Next slide, please. So here's a table where in column 4, these are the confidence intervals that are provided by the University of Alabama in their publication. I also note the p-values in the second column. And then in the last, or in the second column. In the last column are the values we feel are the appropriate ones that you should be relying upon based on past assessments by the agency. And you could do the math as well, but we just thought it'd be easier to provide a table of values here. Next slide. And here's a picture of a histogram that shows the distribution of cumulative exposures in the SBR cohort. And they, as you can see, if you use EPA's life table calculations for 40-year exposure, the point of the benchmark response rate of 1% will put you at that upper right tail. That's not where the point of departure should be. It should be at the lower end. And so that's why we feel that a 0.01% or lower is actually supported for this data set. Next slide. This last comment has to deal with internal consistency.
Okay, so
your
Yeah,
time
so
is up.
yes, this will have, yeah, it's been 45 minutes.
Okay. Internal consistency and there are some differences between exposure and the life table calculations. Please look into these. I provided a spreadsheet for you to look at these. It does have a meaningful impact on the outcome. So thank you very much for your time.
All right. Do you have questions for the presenter from the committee? Dr. Fenner-Chris.
I have a question about your panel process, selecting and convening an advisory panel.
Sure.
How do you handle potential conflicts of interest? Do you ask them to provide you a financial statement to be reviewed by an ethics official like we have to do for SAC?
No, we essentially will avoid, selecting any or actually inviting anybody who is either working in or for us, anyone in the sector for butadiene chemistry. Then we essentially ask panelists that are engaged to basically express whether they have any conflicts of interest. That's as far as we go. If we find that someone is an outlier, and this is one of the values of structured data, if someone is an outlier, we can actually dig into that person a little bit further in terms of demographics and other things, but it's more of a data analysis step that we could go down if we see something unusual going on with one panelist versus the rest of the panel.
Thanks.
Sure.
Thank you. Dr. East.
Thank you. That was very interesting. I had a question. It seems to me that when evaluating interspecies differences, you recommended taking the point of departure and dividing it by a value that was much, much less than 1. So therefore, the effective point of departure became very, very large.
Correct.
Now, I assume this is the typical way of doing this is you would take the point of departure and modify the uncertainty factors to reduce them, so you would end up with a similar sort of thing. Am I missing something here? I mean, it seems very unusual to change the point of departure. There's some twisted, there's some different thinking goes on in this evaluation than I usually do. So can you explain that a little more?
Sure. No, we're essentially following EPA's data-derived extrapolation factor value. So it's basically an approach to coming up with what is the human equivalent concentration corresponding to the point of departure, and then you apply uncertainty factors to that. So essentially, it's the HEC that we're coming up with using the data-derived factor. So it's it still comes into the decision to include additional uncertainty factors on that step is a second piece of it, so it doesn't disappear entirely, but it is fundamentally a separate step of the assessment.
So this is basically deriving an HEC, which is based upon internal dosimetry.
Correct.
Okay, and so therefore you could go up. The effective dose is much higher.
Correct. Exactly the same way if you had a PBPK model.
Okay, thanks.
Mr. Wright.
There we go. This is a bit of history, and kind of full disclosure. I was the representative of the Steelworkers Union in the attempt to get an OSHA standard for 1,3-butadiene, which took place in the mid 80s. The way that standard was achieved was through a negotiated agreement between us and the Rubber Manufacturers Association and the predecessor to ACC, which was the Chemical Manufacturers Association. We recommended a level of 1. OSHA had actually proposed 2 parts per million, but we were able to sort of reduce that to 1, and I think the industry acted very responsibly in doing that. But no one should think that anybody believed that was sufficiently protective at the time. OSHA's risk assessment basically found a risk to a working population defined by OSHA as as 8 hours a day, 5 days a week for 45 years. The risk that was calculated was between 1.3 and 8.1 per thousand, which is considerably higher than any risk that EPA considers. Actually, I think EPA would consider that to be to be very, very high. And the standard was driven entirely by feasibility. And as the speaker told us, the levels have been reduced over the years, and I think that's because the technology has become better and we can do better on feasibility. But at any event, EPA is not allowed to consider feasibility in this stage of the rulemaking process. So I just didn't want anybody to think that the 1 part per million set by OSHA, even back then, was seen as sufficiently protective.
Yeah, I don't recall if that was based on animal studies or the older version of the SBR cohort. In our evaluation,
it was primarily the SBR. The
Okay.
SBR cohort.
Good. That's good. That data has, if it was pre-2004 when they refined the exposure estimates, that had about a 5-fold impact on the potency estimate, if I recall. And then I would also point out that in that slide where I compared the OSHA PEL to the 3 different endpoints, we used a 1 × 10⁻⁴ risk to do that comparison for the cancer risk specific based on the most recent cohort data. So we're certainly below the 1 × 10⁻⁴ at 1 ppm for based on the current data.
Yeah, thanks.
Sure.
Dr. Santos Purua.
Yes, thank you very much for the presentation. Very comprehensive, very interesting data. Really very useful. I just had one question about your slide on the history of the different parameters of the different cohorts. You started that on 2007, but University of Alabama started publishing in 1996, and parameters before 2007 were different. So why not considering why not trying to explain those differences?
Yeah, pre 2007 would be like I said before, the exposure estimates were refined. I also believe in the early 90s, the University of Alabama was doing Poisson regression rather than Cox proportional hazards, and so forth. It's less comparable. So that's why we started essentially post-refined exposure for that comparison. But your point is taken that we could extend it even further. It would be a little bit more difficult, but it could be done.
Yeah, and so it will raise the issue how much you trust this refined exposure assessment.
I believe that they have published on validating and verifying that exposure estimates, but I seem to recall in the late 2000s that they had a considerable effort in terms of providing increasing confidence in those exposure estimates.
A lot of work, yes. Thank you very much.
Sure.
Other question? Dr. Opti.
Yeah, hi. Very interesting presentation. I was just wondering, is Gunnar Bison's data peer-reviewed and published?
Yes. Certainly the male worker data was all published in 2022. The female data are in that process right now. And so
I couldn't find them, so that's the reason. Anyway, the other question I had was, in your metabolism scheme, you seem to exclude the DNA addict part, which is in the EPA document as well as your paper from 2022. And so I was just wondering what's going on there.
Just trying to simplify a very complex slide. EPA, the slide that EPA presented actually from my paper, and for this presentation, I was trying to focus on just the biomarkers and the key metabolites to keep it
That
simple.
doesn't mean that's not a comment on DNA adduct not being
No,
formed?
no.
Okay.
No, I've definitely published on, Dick Albertine, I published a review article on genotoxicity. Absolutely, all three metabolites produce adducts to DNA and can produce genotoxicity. So no arguments there whatsoever.
Yeah. Dr. Mayer?
Oh. Yeah, thanks again for a detailed presentation. I just wanted to make sure I captured correctly for the non-cancer for the DDEF calculation. Is toxicodynamics is going to be, you're kind of considering that one, and the adjustment you're talking about here is based on hemoglobin adducts as the basis for the kinetics adjustment.
Correct, just kinetics, not dynamics.
Okay, and then with regard to toxicodynamics, the evidence for the active metabolite is, if I got it right, there's two lines there. One is that mice versus rats, when you expose to the metabolite itself, they have very similar effects as one, and the other is when you did dose response adjusted for this active metabolite, that makes them aligned. Is that the two pieces you showed?
That's correct.
Okay, thank you.
Sure.
Other questions? So this is George Cobb. I actually have a couple I want to get to. First of all, in your slide 5, I'm was interested at what the actual data were. You've got a bar chart, but you don't have any numbers on it. Possibly if the EPA staff or contractors can pull that presentation up.
Yeah, slide 5, that's the CDC NHANES data. Those are pulled from a paper by Nieto et al. 2021. So I'm simply reporting the means and standard deviations in that paper and putting them in this figure.
Do we have that figure?
Give us 1 second, Dr. Cobb.
Okay.
Thank you.
So you say those data were from the NHANES study, though?
Correct.
So that the numerical values would be in that paper.
Dr. Cobb, do you know what slide you want us to pull up?
5.
5? Okay.
Yes, those are definitely pulled from a paper. I have not reanalyzed any of the urinary biomarker data from that. So I'm simply reporting, relying upon the means and standard deviations as reported by Nieto et al. 2021.
Okay. So we can find that information there then.
Yes.
Okay. And then I was some language in one of your next slides just before conclusions too. I don't remember which slide it was. Just a couple of slides ahead. Back one right there. So just one, yeah, this. It says no, not conclusion 3, before conclusion 2. One more. Yeah, right here. Oh, yeah, I think we stopped right there. So your last bullet towards the bottom, it says exposures are not generally expected to pose an unreasonable risk. What do you mean there?
Yeah, I think we did, depending on what percentile, so our main conclusions are based on the 95th percentile of the resulting distribution, depending on how far you go out there. And I think there were some situations where maybe an error bar might go above a potential benchmark without a respirator use. I'd have to go back and check specifically, but by and large, across the board, that is an appropriate conclusion. There might be some small exceptions, but they can be discussed or managed, at least for occupational exposure in terms of appropriate PPE for that, which is required already by current regulations anytime you exceed the OSHA PAL. So.
Okay, so some risk, but not in all cases. All right. What data, you had something about the percentage of butadienes from fires and those types of things. What do you have data about how the human population, if you will, residents or activities intersect with the areas where the fire plumes are projected, and how we might be intersecting with that?
That's a good question. I have not looked at geographical overlap of industry versus fire risks. That's not something that we've considered, and it would really have to be done on a site-specific risk assessment basis.
Yeah, exactly. I see a couple of other questions, so I'm not going to hog this whole discussion. Let's let Dr. Heiger-Bernays ask a question.
Hi, thank you very much for the presentation and for sharing all of those data. The question I have is actually similar to George's recent statement about that particular conclusion, using the MOE for the fetal outcome information. And I'm just wondering what data are available when you dig into the female data from the exposure, in terms of if there additional data on pregnant women or other information with regard to perhaps a susceptible population that we might not yet have seen. So the question really is not the general population and not the general worker population, but pregnant women or women of childbearing age in these facilities, in the worker population.
Yeah, with respect to the study in female workers, there's, at least for the hemoglobin addict data, which is characterizing the toxicokinetics, I would refer to the paper of Vasek et al. 2010, VACEK. It's Czech Republic workers that both studies were done in, but it's the 2010 paper that they looked at the female workers. I don't think anybody was pregnant. I do suspect some were of reproductive age. I couldn't tell you off the top of my head what the ages were. With respect to pregnancy, and I think some of the questions regarding dosimetry and pregnancy can be known based on understandings of changes in volumes of distribution, which generally decrease the concentration in terms of by increasing volume. There's also some changes in P450s that happen over the course of pregnancy that certainly are modelable and could be answered from a modeling perspective, but I don't think anybody's done any studies in pregnant workers to assess that directly. That's the best I can offer.
Okay, thank you.
Mr. Wright.
Yeah, going back to conclusion one, which showed the impact of 3 different kind of respirators and then no respirator. Was it assumed for the respirator data that the worker was wearing the respirator for the full shift and that it was operating at its assigned protection factor?
Yeah, we used a distribution of protection factors based on a few publications on that topic. And I'd have to refer back to the appendix of the risk assessment to identify those. I don't have those off the top of my head, but they were certainly applied to the entire shift. But it was a distribution, a probabilistic approach that we took. So that wasn't just the conservative protection factor point estimate. We actually considered a distribution of possible protections from each respirator category.
Interesting. Thank you.
Sure.
Dr. Easton.
Thank you. Another question. Recently, there was a paper published by Nakamura et al. That described a novel metabolite, cross-linking agent that was generated by the butadiene diol epoxide. And interesting, on DNA, that's the same as the current adducts from diepoxybutane. But as far as the hemoglobin, do you know of any evidence that shows that some metabolite that may have been formed that would adduct the hemoglobin? Like were they using radioactive butadiene and then isolating? Trying to figure out the dosimetry, because here's an unknown metabolite now that's potentially reactive and could contribute to altering the sort of interspecies evaluation.
Is this the myeloperoxidase generated metabolite, or is this something else that we're?
No, it's basically alcohol dehydrogenase that converts that to an aldehyde, and so you've got an epoxide aldehyde.
Okay.
And then you get, but it rearranges on what's an adduct on the DNA, so the structure is exactly the same as the adduct from the diepoxybutane.
Yeah, I think.
Not sure that would happen on hemoglobin, but I'm wondering if there are other adducts.
Right. I think, the possibility of other metabolites contributing is interesting. I think they're currently at the hypothesis stage. And so in terms of adding them to the relative potency approach, it's could be done, but would require additional data. And you would essentially have to show that the combination of both the internal dose and its toxicity are important contributors to justify inclusion. Because like I said, even epoxybutane, even though we can measure the adducts and we can measure its toxicity and its mutagenicity, it's just not driving the assessment. So it doesn't have to just be measurable. It has to be important in order to justify including it into the quantitative assessment. So right now, I think most of those types of studies are, and I'm aware of at least 2 metabolites that are hypothesized, but they need more information before we can really say this is real or not.
Thanks.
Sure.
Okay. I have a couple of other questions. Well, at least one more, maybe 2. Yeah, so the guys have pulled up slide 15. So if you look here, first of all, it looks to me like the female cohort is non-responsive to this adduct formation. Is that correct, or?
Yeah, I think that the dose response is fairly flat for that. So that's true. But I think that this is also data reflecting additional things, because like I said, this is analytical methods refinement. These are pretty low. So we have some analytical variation here as well. I think also we're characterizing exposure as a point estimate when it's really, there's error bars on the x-axis that's contributing here as well. So, but I think your point is taken. If you adjust to do a regression on the red triangles, it's probably flat. Right. And so what does that mean? I don't know. Another approach would be, rather than trying to look at residuals on a regression, you just take the mean exposure and lump everything as a group. That's another possible way to analyze these data. We decided in our analysis to look at the adduct data as a function of exposure to see these types of trends. But I do take your point.
Yeah, and then just a quick follow-up. The regression lines that you show are with the combined male and female data sets. That's correct.
Correct. That is correct.
Okay. Okay, that'll be all. There's lots more, but we'll spend days talking about this stuff. So thank you for that presentation. And now we have a presentation coming up by Adriana Antezana. I'm sorry. Small print on my screen and bad eyes. So yes, we'd like to hear what you have to say.
Yeah, good afternoon, everyone. And this it's just a 5-minute public written oral comment. So there's no slides or presentation. But thank you for the time to speak today. My name is Adriana Antezana. I'm a staff scientist with Earth Justice. Our team submitted written comments on the 1,3-butadiene risk evaluation, addressing both legal and scientific issues. So I wanted to use my time today to just highlight 2 scientific issues for the SAC to consider: that EPA must quantify people's exposure to residual 1,3-butadiene in polymer products, including from the disposal of these products, and that ovarian atrophy is an appropriate endpoint for deriving a non-cancer point of departure. So first, related to question 3 of the SAC charge, we urge the SAC to encourage the EPA to develop a quantitative assessment of exposure to butadiene from consumer products that use butadiene-based polymers. Polymerization of butadiene molecules always results in some amount of unreacted butadiene monomer to remain. Polymers are used in lubricants, greases, fuels, building materials, tires, and many other plastic and rubber products. In EPA's assessment of consumer exposures, they assert that because the presence of residual butadiene in singular products would be so low that a qualitative assessment was adequate. However, this does not suffice because it ignores the potential aggregate exposures from the use of multiple products. And even then, exposures that are low are not zero, and EPA cannot disregard them because they do contribute to total butadiene exposure. And relatedly, EPA failed to assess exposures to residual butadiene from the disposal of polymer products such as tires and tire crumb that can occur to various populations. Tires are commonly composed of rubber that contain butadiene polymers, and pyrolysis is a common method of waste tire treatment. And one study, pyrolysis of tire tread samples, has been shown to yield 1,3-butadiene monomer. And butadiene was also quantifiable in samples of tire crumb collected from turf fields. And separately, a tire fire at an Iowa landfill resulted in especially high releases of butadiene to ambient air, measured 300 meters away. And so this concentration of 1,3-butadiene in ambient air was higher than the highest measured ambient air concentration that EPA reported in their risk evaluation. So in summary of this first point, exposure to residual butadiene from products and their disposal adds to an individual's total butadiene exposure, and we ask that they be quantified by EPA fully. My second point is related to question 5B3 of the SAC charge. The SAC should recommend that EPA derive a non-cancer point departure for 1,3-butadiene based on a variant atrophy. As EPA presented earlier today, the mode of action analysis asserts that variant atrophy is only relevant to mice because of their greater metabolic efficiency to form DEB. However, EPA's own analysis points to uncertainty in making such a definitive statement, noting that the human relevance of the identified mode of action cannot be reasonably excluded, and that there is a lack of scientific data on the mechanism for which DEB can even cause follicle depletion. Humans do metabolize EB to DEB via CYP2E1. And as noted in the draft human health hazard assessment for butadiene on page 17, there appears to be a 60-fold variability among humans in this metabolism, which is not considered by EPA in the MOA analysis to assess human relevance. So to conclude, we urge the SAC to critically re-examine EPA's rationale for dismissing the human relevance of the variant atrophy endpoint, as there is uncertainty in the proposed mode of action to outright do so. Additional information on my comments that I just presented here, including the sources for some of the claims, can be found in the written comments that Earthjustice submitted to the 1,3-butadiene risk evaluation docket. And we are also happy to follow up to provide these papers. And thank you for listening, and I look forward to hearing the SAC's discussion over the coming days. Thank you.
Excellent. Thank you for your comment. And are there questions from the committee? Well, Dr. Chasen had to leave, or I'm sure she would have a number of questions for you. This is right up her alley of expertise. I did want to ask one clarifying question. You used the term turf fields. Are you talking about athletic fields that have artificial surface? Is that what you mean by that?
In this specific case, I don't know if it was an athletic field, but it was a turf field that used tire crumb. I'm just not aware if there's other uses of tire crumb on turf fields. But yeah, it would be similar to ones that use athletic fields.
Okay.
But I don't know if that specific sample was from an athletic field.
Point taken. I just wanted to double check that I wasn't missing something that I didn't know existed, but it's exactly, I think, what you're talking about. I see Dr. Heiger Bernays has her hand raised.
Hi, thank you very much for that those comments. With regard to the tire crumb, the field, are those data are the data or the study provided in your comments?
Yes, those are in the comments, but I'm also happy to follow up with the study
Okay.
directly hand it to the SAC. Yeah.
That would be great. Thank you.
Thank you.
Other comments? Questions? Well, thank you very much. Really appreciate that comment. Okay, let's go to our next presenter, Paige Varner.
Yep, I'm here. Thank you. Good afternoon. My name is Dr. Paige Varner, and I'm a scientist with Environmental Defense Fund. And thank you for the opportunity to comment. I want to focus my comments today on how the draft risk evaluation excluded relevant exposures and used flawed models to assess risk for defense line communities particularly, and to urge the SAC to encourage EPA to reevaluate these risks in the final risk evaluation. So first, EPA failed to include 1,3-butadiene releases from accidental or irregular releases, such as from startup, shutdown, malfunction, transportation accidents, and other leaks and spills. However, as these releases are reasonably foreseeable, the SAC should urge EPA to include them as relevant exposures. For example, EDF analysis found in 2020 alone, there were over 3,000 startup, shutdown, and malfunction events just in the state of Texas, which released nearly 17 million pounds of multiple hazardous air pollutants, including 1,3-butadiene. These represent a significant magnitude of the releases, especially when compared to the 48 million pounds of stack and fugitive releases of these HAPs reported in Texas in the 2020 TRI database. All these releases are particularly important to account for in an acute exposure assessment because these releases often result in very high concentrations of 1,3-butadiene in short time frames. However, EPA did not consider risks from acute exposures at all in this risk evaluation, and so we urged the SAC to encourage EPA to derive an acute point of departure to assess fence line community risks to these accidental but often extreme exposures, or utilize the intermediate point of departure to assess these risks. EPA also failed to include other relevant exposures of 1,3-butadiene. So for example, EPA didn't consider exposures from non-TSCA sources of 1,3-butadiene, such as vehicle exhaust, smoke, or wood burning in its risk assessment. The SAC, as it has done in the past, for example, in reviewing EPA's evaluation of the phthalate DIDP, should encourage EPA to consider these contributions of the contribution of TSCA sources of 1,3-butadiene to the overall exposures that an individual might face. Next, EPA used flawed models and scientific methods in assessing the risk to the general population or fence line communities from ambient air. So for example, though EPA claims to have conducted its fence line risk assessment using both modeled and monitored data, EPA did not in fact actually incorporate any monitored data into its calculation of risk. This has likely resulted in an underestimation of risk because multiple studies, including EPA's own analysis for the hazardous organic NESHAP or HAN rule, found that modeled concentrations of 1,3-butadiene underestimate true exposure concentrations by up to 69 times. Further, the tiered modeling approach employed in the draft risk evaluation screens out potential risks. So use of the IIOAC model as the first screening step is illogical because it is a narrow model, and EPA fails to use it to capture risks from multiple neighboring facilities releasing 1,3-butadiene. On the contrary, the HEM or human exposure model is able to capture risks to fence line communities that reside near multiple facilities releasing 1,3-butadiene and expands to both smaller and larger distances. Therefore, the HEM should be used as a first step rather than a last to investigate the aggregate risks associated with multiple sources of 1,3-butadiene exposures. Lastly, while we definitely support EPA's intent to incorporate analysis using NEI data alongside TRI data in its risk evaluation, EPA's supplemental analysis of general population risks from 1,3-butadiene in ambient air is flawed. Not only are there calculation errors, such as switching the values for columns representing stack height and gas exit temperature from the 2020 NEI data, but is an extremely narrow analysis focused on only risks from just 9 individual facilities rather than the 47 facilities addressed and assessed using TRI data, which excludes 3 of the highest emitting NEI facilities. These errors and methods significantly underestimate exposures and therefore risks. The supplemental analysis also failed to include all NEI releases from individual facilities and across all facilities releasing 1,3-butadiene. So for example, the Shell Chemical Norco plant, EPA only included releases from petroleum refineries operations and not all other basic organic chemical manufacturing operations, which is undoubtedly subject to TSCA risk evaluation and regulation. So we urge the SAC to encourage EPA to incorporate complete and aggregate analysis from all relevant NEI facilities releasing 1,3-butadiene rather than relying on this narrow supplemental analysis. Thank you for your time. These comments and including their sources to some of these studies have been included in our written comments, including other comments that I urge you to look at. And thank you for your time and service.
Thank you for that comment. I see a hand raised by Dr. Hopkins.
Thank you for, I don't appear to
We
be.
hear you.
Okay, I'm sorry, Dr. Varner. I can't, my camera's not working. I did want to ask you about the startup shutdown concentrations. Are you recommending that they would be something that you would feel confident as reported by in the NEI, or are you suggesting the actually monitoring data that would back that up?
Yeah, ideally monitoring data if it's available. I also think that accidental releases aren't all captured in NEI, I don't believe. I would have to double check. But there are other databases such as like the STEERS database in Texas, which I know you know very well, that have more information on accidental releases. So ideally monitoring data if it's available is the first priority.
Thank you very much.
Dr. McKenzie.
Thank you for that presentation. It's interesting. So I wanted to ask you about, you referred to in the beginning about, I think it was approximately 3,000 releases in Texas alone. Were those clustered in a particular area of Texas?
I would have to go back and look at the analysis. It's linked in our comments if you do want to go back and look at that. I assume most of it would be clustered along the Gulf Coast, where a lot of the petrochemical facilities are. Yeah.
So kind of, I'm getting at, the potentially exposed susceptible subpopulations that might be.
Yeah, exactly. And there's additional research included in there that a lot of these startup shutdown and malfunctions are due to extreme weather conditions. So it would also make sense that along the Gulf Coast where these facilities are located, there's a high risk and increasing risk as time goes on, obviously, from climate change of extreme events.
Thank you.
Thanks.
Other questions? I actually have one. You mentioned the three highest releasing facilities were omitted from EPA's analysis. Do you happen to remember what those three highest emitting facilities were, or is it in your written comments?
Yes, I believe it's in UCSF's written comments.
Okay.
They're definitely in there. They're in a table in there. I believe they're in Texas. I don't have them pulled up right now. Apologies.
Well, do not worry. It's in your written comments, and that's why you provide them so we can go back and look.
Yeah.
Okay. Well, thank you. And thank you for that comment. I think that concludes our commenters for today. And it puts us just about exactly on time for an on-time conclusion. So I'll turn this back over to Ms. Muneer.
Yes, thank you, Dr. Cobb. So I want to thank everyone for participating in today's first day of the SAC meeting for the 1,3-butadiene peer review. Thank you for the wonderful presentations. I personally really enjoyed them. And thank you everyone for making your public oral comments. I would like to now turn it back over to Dr. Cobb to make any further closing remarks before we officially adjourn.
I just would like to thank everyone from EPA, the public, and the committee for participating, all the contractors, and we will see everyone back tomorrow at the same time. I believe that was 10 a.m. Eastern time tomorrow. Is that right, Allie?
Yes, that is correct. 10 a.m.
All right. I think we're good then.
All right. Thank you, everybody.